음향 감독님, 여기 소리 좀 더 켜주세요. 네.
네, 여러분 저희 잠시 후 2023 건강보험심사평가원 국제심포지엄을 시작하겠습니다. 함께 하실 분들께서는 장내로 입장해 주시고 착석해 주시길 부탁드립니다. Distinguished guests and ladies and gentlemen, may I have your attention please? We'll soon commence the opening ceremony of the HIRA International Symposium. Ladies and gentlemen, please enter the hall and be seated. And if you need any translation service, please use the receivers on your tables. Channel 1 is for Korean and channel 2 will be for English. Thank you. 네, 여러분 다시 한번 동시통역 서비스 안내 드리겠습니다. 아직 리시버 없으신 분들께서는 데스크에 가서 수령해 주시고 다시 입장해 주신 후 착석을 부탁드리겠고요. 오늘은 한국어는 1번, 영어는 채널 2번입니다. 고맙습니다. 네, 여러분 안녕하십니까? 2023 건강보험심사평가원 국제심포지엄에 오신 여러분을 진심으로 환영합니다. Distinguished guests and ladies and gentlemen, welcome to the HIRA International Symposium 2023. Before we begin, please allow me to introduce myself. My name is Jessica Singili, and today I've given the honor of being your MC for this very special and meaningful gathering. 네, 여러분 시작에 앞서 먼저 인사 올리겠습니다. 이 뜻깊은 자리 저는 사회자로 함께하게 된 아나운서 이승희라고 합니다. 인사드리겠습니다. 네, 고맙습니다. 좀 이른 시간에도 불구하고 또 귀한 걸음해 주시고 현장을 빛내주고
First and
계시는
foremost, I'd like to express deep gratitude to our esteemed guests, speakers, and on-site participants who have graced us with their presence despite their busy schedules. I would also like to extend sincere thanks to those joining us online, as the symposium is being live-streamed on its official website, as well as the HIRA YouTube channel.
여러분 오늘 끝나는 시간까지 저희와 함께 해주시고 많은 도움
I hope you will stay with us until the very end, and I look forward to listening to your insights.
먼저 오늘 심포지엄 시작에 앞서서 다시 한번 동시통역 서비스 안내를 드리겠습니다. 오늘은 한국어와 영어 동시통역이 제공이 되고요. 한국어는 채널 1번, 영어는 채널 2번입니다. 원하시는 언어로 설정해서 청취해 주시길 부탁드리겠습니다. Distinguished guests and ladies and gentlemen, before we begin, for your information, we do provide simultaneous interpretation service. Channel 1 for Korean and Channel 2 is for English. Please select your language of choice. Thank you very much for your kind cooperation.
HIRA annually organizes this international symposium to share insights into healthcare insurance systems from around the world, exchange expertise in quality management, and address salient issues. The 2023 symposium is focused on the theme preparing for the future healthcare system by strengthening the integrated healthcare system. Our discussions will emphasize the challenges of the healthcare system development in response to pandemics and aging societies, efforts and directions for enhancing healthcare service outcomes, and the utilization and challenges of ICT for improving healthcare quality.
또 다양한 시각을 공유하는 뜻깊은 논의의 장이 될 예정입니다.
Before we proceed further, let us provide instructions for emergency procedures to ensure event safety. In the event of an emergency, please use the designated exits to evacuate the premises. To ensure safety, please follow the guidance of the safety personnel and evacuate calmly to avoid any potential accidents. Now, without further ado, let us commence the opening ceremony of the 2023 HIRA International Symposium. Our first segment features Dr. Jung Kang, President of HIRA, who will deliver the opening remarks.
Now, please join me in welcoming Mr. Kang Jung-gu, President of Health Insurance Review and Assessment Service. Ladies and gentlemen, let's welcome him with a big round of applause. 여러분, 큰 박수로 환영해 주시죠.
Good morning, ladies and gentlemen. I'm Jung Kang, President of the Health Insurance Review and Assessment Service. It is my privilege to extend a warm and sincere welcome to all distinguished participants of the 2023 HIRA International Symposium. I'm delighted that this significant symposium has come to fruition through the keen interest and strong support of healthcare experts from around the world. Allow me to express my special gratitude to those wonderful professionals who have graciously accepted our invitation despite their demanding schedules. In this symposium, we are honored by the presence of esteemed individuals who have traveled from afar to join us, including Professor Jeffrey Braithwaite from Macquarie University, Ms. Salma Jaouni, CEO of the Healthcare Accreditation Council, Dr. Joel Roos, Vice President of the Joint Commission International, Dr. Anthony Staines, Director of the Hospital Federation of VOD, Professor Yuichi Imanaka from Kyoto University, and Dr. Carsten Engel, CEO of the ISQua. We also extend our sincere gratitude to all domestic and international speakers and attendees who have graced this occasion. Today's symposium revolves around the theme, Preparing for the Future Healthcare System by Strengthening the Integrated Healthcare System. This stands as a paramount endeavor in the pursuit of advancing and evolving healthcare. Enhancing medical quality and harnessing the potential of ICT systems are crucial for building an efficient and secure healthcare network. The exchange of experiences and insights from healthcare professionals, both domestic and international, about these core issues carries deep meaning for us. Throughout the symposium, our goal is to collectively explore diverse topics that are vital for adapting to the evolving healthcare landscape and preparing for the future healthcare system. We hope that the shared knowledge and perspectives today will foster innovative ideas and solutions for the future of healthcare. I look forward to your productive discussions and creative ideas. Lastly, HIRA remains steadfast in our commitment to universal healthcare coverage and the development of a global healthcare system. We look forward to continued collaboration with healthcare experts worldwide to drive policy advancement in the healthcare domain. Once again, I extend my heartfelt appreciation for your valuable time. May this symposium play a pivotal role in driving positive developments in the global healthcare arena. Thank you.
네, 원장님 따뜻한 말씀 잘 들었습니다.
Dr. Kang, thank you so much for your opening remarks.
심포지엄의 주제와 취지에 대해서도 언급을 해주셨고요. 함께하신 모든
Dr. Kang
분들께
touched
감사
upon
인사까지
the theme
전해주셨는데요.
of the
다시 한번
symposium and
마무리
also
해주신
express his
원장님께
gratitude
진심으로
for the
감사를
esteemed
드리겠습니다.
guests today.
자,
Thank you
이어서는
so much.
현장에는 함께하지 못하셨지만 영상으로
Next, we have
축하
some
말씀을
distinguished
들려주신
guests who could not be here in person but sent their
먼저
video
국회
remarks to congratulate the
보건복지위원회 신동근
symposium.
위원장님의 영상 축사를 만나보시겠습니다. Next, we will watch a congratulatory remarks delivered by Mr. Shin Dong-gun, Chairperson of Health and Welfare Committee of the National Assembly through a video. 여러분, 화면으로 함께 만나보시죠.
Good
morning, everybody. My name is Shin Dong-gun, the chairman of the National Assembly Committee on Health and Welfare. I'd like to extend my sincere congratulations to you for organizing the 2023 HIRA International Symposium. I'd like to thank Dr. Jung, the president of HIRA, for providing a meaningful forum for the development of the healthcare sector and all of the domestic and international healthcare experts. The theme of the 2023 HIRA International Symposium is preparing for the future healthcare system by strengthening the integrated healthcare system. In pursuing the transformation and development of healthcare, ICT systems, healthcare quality improvement are common challenges to be addressed globally within various healthcare systems and are essential for an efficient and safe healthcare network. Today's symposium is a valuable opportunity to share and discuss the changing healthcare environment and sustainable future healthcare systems with a variety of domestic and international healthcare experts. We hope that this symposium will serve as an opportunity to respond to various changing environment and promote cooperation for the development of the future healthcare system. As the chairman of the Health and Welfare Committee of the National Assembly of the Republic of Korea, I look forward to working with you going forward. Thank you very much.
네, 여러분 큰 박수 부탁드리겠습니다. 네, 멀리서나마 이렇게 따뜻한 축하 영상을 보내주신 위원장님께
I'd like to thank
감사드릴 텐데요.
the chairperson once again for sending a congratulatory remark. He talked about how it was meaningful that we're here to talk about a future healthcare system.
박민수 제2차관님의 영상 축사를 만나보시겠습니다. Next, 박민수, the second Vice Minister of the Ministry of Health and Welfare of the Republic of Korea, has also sent us a meaningful video. 여러분 화면을 통해 함께 만나보시죠.
안녕하십니까.
Good morning. My name is Kang Min-soo, Second Vice Minister of Health and Welfare. I'd like to express my gratitude to the distinguished guests from Korea and abroad for taking time out of their busy schedules to attend the HIRA International Symposium. Healthcare in Korea and around the world is facing a major challenge of aging. As a result, the focus of healthcare paradigm is shifting from treatment to prevention. In response, it is time to change and innovate towards an integrated care system that provides comprehensive patient-centered care. To successfully establish such an integrated care system, it is necessary to align the two pillars, sustainability and quality improvement of healthcare. To this end, the Korean government is committed to checking unnecessary healthcare expenditures and ensuring that limited financial resources are used for essential healthcare services. At the same time, the government is supporting the utilization of healthcare data, which is fundamental to improving healthcare quality and fostering future-oriented investments in prevention-oriented healthcare. For the past 20 years, HIRA has been managing healthcare expenditures, including coverage decision, claims review, and post-management, and promoting quality improvement of healthcare through the accumulation and management of healthcare data. The Korean government will continue to strive for the development of global healthcare through cooperation with relevant organizations such as HIRA in line with international trends. Through today's international symposium, I hope that participants will discuss the present and future of healthcare and find solutions for the direction of global healthcare. I'd like to express my deepest gratitude for your participation. Thank you.
네, 여러분 큰 박수 부탁드리겠습니다. 네, 차관님께서 국민의 의료제
Thank you, Second Vice Minister Park, for your welcoming remarks.
해주시겠다는 말씀도 해주셨고요. 또
Thank you for your warm
국제
anticipation and
보건의료
also
행사를
sincere words of encouragement for the
다시 한번
symposium. Thank you again.
감사드리겠습니다. 자, 여러분 다음으로는 본격적인 행사에 앞서서 이 자리를 또 기념하고 축하하는 의미의 기념사진 촬영이 있겠습니다. 오늘 기념사진 촬영은 총 2번에 걸쳐서 진행이 됩니다. 먼저 첫 번째 사진 촬영은 강중구 원장님 무대 위로 올라와 주시면 고맙겠습니다. 그리고 심사평가원 원장님을 비롯한 임원진 여러분들도 올라와 주시고요. 그리고 연사분들도 무대 위로 모시겠습니다. Now we will have a group photo shoot. We would like to welcome our president and officials from HIRA and our distinguished speakers. Please come up to the stage. 네, 무대 위로 모시고 국제 심포지엄 개최를 축하하는 사진 촬영 먼저 함께 하시겠습니다. 네, 원장님께서 좀 중앙에 서 주시고요. 네, 양쪽으로 도열을 부탁드리겠습니다. We'd like to have President Kang at the center and our speakers and officials please make one line. 네, 한 줄로 좀 서 주시면 고맙겠습니다. 네, 앞쪽 카메라 봐주시고요. Please look at the camera at the center and make a big smile. Thank you. 활짝 웃어주시고요. And now, ladies and gentlemen, let's give a big round of applause to each other on the stage. Our distinguished guests, please give a big round of applause as well. 네, 무대 위에 계시는 분들도 박수 한번 부탁드리겠습니다. Please give a big round of applause. 원장님도 박수 쳐주시고요. 카메라를 봐주시면 되겠습니다. 네, 고맙습니다. Please remain on the stage. 네, 이어서는 저희 심사평가원 부소장님과 심사위원 등 내빈분들께서도 무대 위로 올라와 주시겠습니다. And now we'd like to welcome department directors of HIRA and the committee members of HIRA as well. Please come up to the stage. 네, 이번 두 번째 촬영은요, 정말 많은 분들께서 함께 해주실 예정입니다. 네, 따라서 무대 위에 올라오시는 분들께서는 앞쪽에 서 계시는 분들 사이사이에 잘 보이도록 좀 서 주시면 고맙겠습니다. Ladies and gentlemen, please make sure that your face is well shown to the camera. 네, 여자분들은 좀 앞쪽으로 나와 주셔도 좋을 것 같고요. 네, 무대 위로 모두 모시겠습니다. 네, 저희는 이번 기념사진 촬영을 마지막으로 본격적으로 세션 시작하도록 하겠습니다. 자, 여러분께서는 카메라를 좀 잘 봐주시고요. 네, 죄송하지만 무대 왼편으로 조금 더 이동을 부탁드리겠습니다. 죄송합니다. 네, 무대 왼쪽으로 좀 이동해 주시고요. 네, 이제 정돈이 된 것 같습니다. 네, 사진 촬영하겠습니다. Please look at the camera, make a big smile once again. 활짝 웃어주시고요. 네, 여러분 다시 한번 큰 박수 부탁드리겠습니다. 박수 한번 치면서 사진 촬영하겠습니다. 네, 원장님과 연사분들께서도 다시 한번 큰 박수 부탁드리겠습니다. Please give a big round of applause. Please look at the camera once again. 네, 자연스럽게 활짝 웃어주시고요. 고맙습니다. 자리로 들어가 주시죠. 네, 원장님과 연사님들 먼저 좀 자리로 돌아가 주시면 되겠습니다. Thank you for your cooperation. Please now return to your seats. 네, 다시 한번 현장에서 크게 박수로 축하해 주시고 또 멀리서나마 저희와 함께 힘을 더해주고 계시는 모든 참석자와 시청자 여러분께 감사를 드리겠습니다. 이제 저희 지금부터는 본격적으로 심포지엄을
And now,
시작할
let us
텐데요.
begin today's
오늘
symposium.
진행되는 발표는 한국어와 영어로 진행될 예정이니
We will provide the speeches in both Korean and English, so please make sure to use your receivers.
네, 지금부터는 발표를 시작하겠습니다. 먼저
So
첫
now
번째
let's begin with the
준비
first
순서는
keynote
기조
speech.
연설입니다. 오늘은 제프리 브레이스웨이트
We have Mr. Jeffrey Braithwaite, the president of ISQua,
잠시 회장님 소개를 좀 드리겠습니다.
and let me introduce him
제프리
briefly.
회장님은 전도적인 보건
ISQua
서비스 및
is
체계
a
연구자십니다.
member-based non-for-profit community and organization dedicated to promoting quality improvement in healthcare. And President Jeffrey Braithwaite has gained international recognition as a pioneering health services and systems researcher through achievements such as investigations into system improvements. Today, he will give us a keynote speech on the topic, Can we make a better healthcare system by 2030?
Now, please welcome Mr. Jeffrey Braithwaite, President. Please come up to the stage. 네, 여러분 큰 박수와 함께 무대로 모시겠습니다.
Good morning, President Kang, colleagues, and distinguished guests, and HIRA colleagues. Could I thank you very much for the kind invitation to speak to you this morning about making a better health system. And I'd like to address my remarks not just to here in Korea, but also can we make better healthcare systems around the world by collaboration? We have recently been to the ISQua conference here in Seoul in Korea, and we have been exploring many aspects of better healthcare. So let's talk about that this morning and think, can we make a better health system by the year 2030? We know that health systems are facing many, many challenges here in Korea and internationally. So I'm from the Australian Institute of Health Innovation when I'm not being the president of ISQua, and I am a researcher running a lot of research programs on health systems improvement. How do we create high quality, safe care right across the world? So we have seven research centers in our research institute, and we're all doing work to try and improve continuously quality of care, which in a way is what HIRA is trying to do, to try and help improve healthcare here in Korea. But we do it by doing lots of research studies, deep research studies to understand healthcare deeply. So, who has been to Sydney, Australia? So here is a wave from some of my staff in Sydney, Australia to you here in Seoul, in Korea. They are saying hello to you. So we have a lot of research. We run about $50 million worth of research and another $80 million of research that we participate in elsewhere in Australia and around the world. We have 129 projects, and we publish a lot of peer-reviewed publications across the international literature. And why I say that is I'm going to draw on some of that work to make my presentation today. So one of the things I've learned as a researcher, as a professor, is to try and figure out what it is that is the problem that we are trying to solve. Now, we have many problems in healthcare, but here's what I think is the problem I'm trying to solve. It takes about 17 years for only 14% of new discoveries to get into clinical practice. About 60% of care is in line with evidence or guidelines. Around 30% of care is waste, and we heard the second minister speak about trying to make sure economically that the money spent on healthcare is spent efficiently and wisely. But in health systems, we can often count the waste as about 30% of all total expenditure. And 10% of patients are harmed when receiving care. So those numbers are very important. So I've published about those numbers in a journal, in one of the big medical journals, BMC Medicine, with some colleagues, about this phenomenon. 60, 30, 10. 60% is in line with guidelines or level 1 evidence. 30% is waste. 10% is harm. So these are big problems to solve. So if we just looked at those three numbers and we tried to improve the quality, get more care in line with level 1 evidence, say, reduce the waste and reduce the harm, we would have a better health system here in Korea and elsewhere in the world. So many health systems have many indicators, many indicators of success, key performance indicators. But our work suggests if we just tackle those three numbers and improved on them, we would have a better health system. And then if we continuously improved on them, we would have a continuously improving health system that would have higher quality, less wastage, less harm. Now, that can't be easy to do because those numbers have stayed relatively stable across the last 30 years. So we've been trying in different ways to improve on those numbers, but we haven't really done so continuously and in a forceful way. So, what have been the solutions? If that's the problem I'm trying to solve with my research, and I'm trying to encourage countries across ISQua to solve with me that problem, to work on that problem, if that's the problem, what's the solution? So one solution is the knowledge pipeline, that we should do more research and do it better and work harder to get that research into practice so that we effect practice on the front lines of care where clinicians treat patients, and the care then is higher evidence, less wasteful, less harmful. But there's a problem with that because the pipeline is an idealization. It's not actually something that's real. It's an approximation of how things work because there's lots of blockages in the pipeline that lead to failure. So the pipeline often doesn't work. The evidence doesn't get into practice. It doesn't get into clinicians' hands. The volume of the evidence that we're dealing with, by the way, is massive. There are 36 million papers in PubMed. There are 36 million papers in PubMed. There are 75 randomized trials and 11 systematic reviews published every day. Every single day. So, sorry, the slides. So that's the problem. And the solution is often seen as we need to get the pipeline going better and get more care on the front lines of care where the clinicians and the patients meet. But another problem that we face is it's a very complex system. The health system is extremely complex. It's much more complex than, say, the banking system or the military system or the manufacturing system. Healthcare, the healthcare sector, is the most complex thing any humans have ever devised. And so we're having to try and get change to a health system that is extremely complex. So the pipeline model, where we say do more research, do it better, get it translated, put it into practice, suggests our solutions are linear, that we go through each stage and get better care on the front lines where the clinicians and the patients meet. But the solutions that we really need are not linear because it's a complex system, a very complex system. The health system is complex, incredibly complex. And so that's the major challenge. How do we get meaningful change and meaningful evidence-based change to the front lines of care in a complex system? Now, you know, complex systems are everywhere. The health system is just the most complex system I know. But your family and your extended family and your friends, that's a complex system. And the IT system and your iPhone connected to other IT systems and other iPhones and other computers, that's a complex system. The Korean Parliament, politics, that's a complex system. The thing you're carrying around at the top of your brain stem, your brain, is a complex system with lots of action going on right now, I hope, when you're listening to me, in the synapses in your brain. That's a complex system. Some neurologists have said the brain is the most complex thing in the universe. Well, maybe the brain is the most complex thing in the universe, and maybe it isn't. You can be the judge. So how does care actually work? Is the question we really have to ask ourselves. If we're going to get evidence through a pipeline all the way through into practice, through this complex system that we call healthcare, we have to understand, how does healthcare actually work? So we published a paper on this recently, a white paper in our research institute called Complexity Science in Healthcare, a white paper. If you go to my website at the Australian Institute of Health Innovation, you can download a copy. Unfortunately, we haven't written a version in Korean. It is in English. Maybe we should get it translated for you. Could I ask the organisers if they wish to see me afterwards, and we'll see if we can get this translated into Korean, if this is of interest to you. What this white paper does is it explains the complexity of the health system and why it is that it's hard to get an improved health system by 2030. So let me just give you a little bit of a summary of that, because I know you may not have read that white paper. You may not have had a chance to read it up to date. So let me just summarize it. So a complex system like healthcare, which is the most complex system, has lots of agents, people interacting, using things, artifacts, stethoscopes, computers, MRI scanners, emergency trolleys, drugs, technology, devices, all the things that they use, artifacts. They are interacting in complex ways that we can't predict. Dynamically, that is, they're changing the way they interact over time, minute to minute, week to week, day to day, hour to hour. And there are all sorts of rules that emerge all the time, and they are governed by some sort of authority, say a policy or a guideline, or they themselves work out ways to work together in clinical teams. And there's lots and lots of mechanisms and bottom-up networks, that is, clinical teams on the front lines of care interacting to produce treatment for patients. So that's a description in four points, about a 100-page white paper on complexity in healthcare. And there's two versions of complexity that you see. This version of complexity is the organizational structure, with the CEO at the top and then all the layers all the way down to the clinicians and the patients on the front lines. And that shows you where everybody has a place in the system. That's one version of the complex system. But you know, healthcare doesn't really look like that. That's a very clean version, a very pure version of healthcare, because healthcare really looks like that. Healthcare really looks like the second diagram. It's lots and lots of people doing lots and lots of things, informally chatting to each other, discussing cases, trying to have a committee meeting about new policy, trying to get care in place in a very complex set of connections and interactions. So the first version is one version of the way healthcare works, from the CEO, the chief executive, all the way through to the clinicians on the front lines. And the second diagram Perhaps that's the way care really gets delivered. And by the way, that second diagram isn't a diagram of the whole health system. It's simply an emergency department. The interactions, the causal loops in an emergency department. I don't have a slide, a PowerPoint slide big enough to show the complexity of the whole Korean health system. It's not feasible. So that's the order of complexity that we are dealing with when we are trying to improve healthcare and get a better health system by 2030. So there's two versions of complexity. There's this one and there's this one. And we have to make both work well if we're going to get a better health system. So we have to get people in the right place in the organizational chart with the right understanding of their task and their work. But we also have to figure out how to manage all of the interactions and make them produce better care on the front lines. So we've done a lot of research in this area in Sydney, Australia, and across Australia, thinking, how do we understand this complex system? Because we have to understand it to be able to improve it. We have to understand it to be able to improve it. So here's a research project we've had going for 11 years in trying to get better cancer delivery of care to cancer patients in an evidence-based way in Sydney, Australia. Now, if you've been to Sydney, Australia, and some of you put your hands up, then what you will know is there's a place called Bondi Beach, and there's an opera house, and there's a harbour bridge, Sydney Harbour Bridge. So in the health services around that area, between Bondi Beach and the opera house and the Sydney Harbour Bridge, there's a whole lot of population living, and this is the care we were trying to improve, the care for those people. We're trying to get better cancer care to those people in an evidence-based way. So we set up a network. Now, you have many networks, many clinical networks in Korea. So we set up a network, and in 2012, the dots are people like me, or people delivering oncology care, and the lines between the dots are the connections between them. So this is a network diagram, a map of the network. That's the way the network looked like in 2012, and that's what it looked like in 2013. So we were getting more people interested in how do we get more evidence-based care to cancer patients in Sydney, Australia. And that's what it looked like in 2015, and that's what the network looked like in 2017, and this is what the network looked like in 2021. So we now have lots and lots of clinicians, oncologists, surgeons, like your president, a surgeon dealing with cancer care. We had lots and lots of cancer nurses and allied health professionals and researchers like me, all working in 2021 to try and get more evidence-based cancer care in Sydney, Australia. And we've been running this project, as you can see, for 11 years. Here's another example of the way we're working to try and understand the complexity of the system and how we might therefore improve it. I'm a member of Australian Genomics, trying to get genomics data into clinical practice, trying to get clinicians to have genomics data. So routinely, they do a history, have test results, and also have genomics data so that they can get precision medicine and specific care for that specific patient in front of them. So this is the network map of the medical scientists, genetic specialists, medical specialists and researchers in Australian genomics in 2016 when we started this big program. We'd been doing some work before that on genomics. This is when we started off a big program. And this is what the network diagram looked like by 2018. This is across Australia. We've got now many people working with us, really together, collaborating together to get genomics from being just a research project to actually having genomics data routinely for patients and for clinicians to provide better care. So lots of countries are doing that. Korea's doing that, and lots of countries are trying to do this. But we've got the network map to show who's connected to whom and who's working in our network collaboratively. So this tells you about how the complex system is working to try and improve care to patients. So the next part is, okay, we're doing all this work, other countries are doing work, trying to improve care. How do we get to 2030? So, I'm the editor of a series of books on international health reform, these 3 books. And this book is about healthcare systems, future predictions for global care. And it looked at what are we going to do to try and create a better health system by 2030. So this was a book. I could talk about the other books, but there isn't time. The third book was the one we looked at to say, how do we get a better health system by 2030? So here it is. It's on Amazon if you want it, but I'm going to do a summary of it now. There's basically 148 authors across the world writing chapters covering 152 different countries, all of whom contributed to this book. And here's a summary of the whole book in our ISQua journal, the International Journal for Quality in Healthcare, which is, by the way, an excellent journal. Don't you agree, Professor Yuichi and Dr. Carsten Engel? It's an excellent journal. And this is on open access. You can access this, and it's a summary of all of this work, which I'm going to explain now. So what lessons can be taken from this global outlook of how we might have a better health system by 2030, working with all this complexity, all these complex adaptive system features of healthcare? So all the coloured in countries are the ones in the book, and the grey ones, there were some countries that we didn't get to in South America and a couple of other places we didn't get to by the time we went to publication. So there are 5, this is what the book says. I'm summarising the book now in a couple of slides. There are 5 main trends running through health systems and shaping health systems of the future. And you can tell me if this applies to Korea. I think it does. One is everyone's working on trying to create a sustainable health system. In fact, you said that at the very start of this conference. People are working on how to get genomics and precision medicine. The third trend is to take advantage of emerging technologies, new drugs, new equipment, new diagnoses, new treatments, robotic surgery, all the new advances, artificial intelligence. Also, the global demographic dynamics are changing. Another trend is populations are aging and have more complex and chronic conditions. And the fifth one is every health system is shaped by new models of care, such as that came along when the pandemic happened and everyone moved to teleconsultations or telehealth. So these are happening now. These trends are going on to a greater or lesser extent in every health system. And what people are doing about those trends is 9 major initiatives across the world, in every health system across the world. These 9 major initiatives are being promoted or adopted. One is trying to integrate care, and some other speakers are going to talk about how to join up care better, integrated care. Another one is getting the finance and economics and the financing and economic incentives in the right place. A third one is patient-based care and empowering the patient. A fourth one is universal health care, what the WHO promotes, which is to have coverage right across the health system. A fifth one is to exploit information technology and technology generally. New IT systems, better ways of wiring up, 5G for example, new IT systems to deliver better care, electronic health records that are getting better and improving. A sixth one of the 9 major initiatives are dealing with aging populations, perhaps patients who are in residential aged care facilities. A seventh one is preventative care, not just focused always on acute care, but focused on prevention as well. An eighth one is what Salma Jaouni is a world expert on, and some other people in ISQua, which is accreditation and standards and policy. How do we get the accreditation and standards and policy settings right? And a ninth one is the workforce. We can't do any of this unless we've got a trained, motivated, inspired, well-performing workforce. So there's 5 major trends running through health systems and 9 major initiatives that everyone in the world is working on to a greater or lesser extent to produce a better health system by 2030. So the question might be forming in your mind, how do we get to this version of 2030? Well, here it is in a snapshot. We're trying to move from fragmented care and siloed care to cohesive joined-up care. That's integrated care. We're trying to move from volume-based care, just treat more patients, to providing value to patients, provide a valuable experience and value-based outcomes. We're trying to move from provider-oriented care, where the provider knows best, to person-centered, where we have co-production. And if you went to the ISQua conference, or you get the slides and the videos from the ISQua conference that we just held, that was a major theme, co-production. We're trying to get to reduce the barriers to access to care and affordability and provide universal coverage. We're trying to exploit information technology. We're trying to get healthy populations and health literate populations, populations that understand what we're doing with them in a co-production sense. We're trying to do more preventative care. We're trying to get high quality, safe, standard-based care through accreditation and standards and policy. And we're trying to continuously improve the workforce to 2030 so the workforce is very, very well trained, organized, motivated, and inspired to deliver care to us, to deliver humane care better than they do now. So, there's many other ideas. I'll just leave you with a couple of slides to tell you about some other ideas about how do we get to this vision of 2030 that 148 authors in 152 countries all put their minds together to design this map, this roadmap to the future for healthcare. So people need a transformation, a change management framework or strategy. And this includes, there's one from the World Health Organization. I'll just leave you with these. There's lots and lots of others. There's lots and lots of other models for change and improvement. And I know you use some of these in Korea, or you have your own special Korean change management transformation models. So there's lots and lots of models. I've just put a few on a slide just to remind you there's lots of ways for us to look at how do we change and improve and transform the health system so it's the best health system we can have for the populations that we serve here in Korea and around the world by 2030. So, I've put a couple of slides with lots of change models. You can have a look at these because the slides are available for you if you would like a copy. The other thing we do a lot in ISQua is we think about change in a long-term way, not just what do we have to change tomorrow to fix something. And we love this model of continuous improvement across time. Deep in our hearts in ISQua and in my research institute, we have the model of continuous improvement. We will never have a perfect health system, not today, not in 2030, but we can have a better health system, bit by bit. And so across time, we should all of us be thinking, how do we each contribute to a better health system across time? That is all I want to say. I'm happy to take questions. If not now, please, Madam MC, if not now, then I can take questions in the break because I will be here for the rest of the day.
네, 고맙습니다.
Just one final thing. I'd like to acknowledge
Yes.
some of my teams in my research institute who helped me do all this research. Here are some recently published books that I have published. Have you read all my books? Here is how to find me if you have any trouble, but you can Google me as well. Thank you very much. MC, I think I've finished on time.
Yes, thank you very much. Thank you. And for questions, I think we can take some questions from the floor at the panel discussion session. So this brings us to the end of our first keynote speech. 네, 고맙습니다. 질의응답은 저희 마지막에 준비된 패널 토론의 시간이 허락하면 받도록 하겠습니다. 이로써 첫 번째 발표는 여기서 마무리가 될 텐데요. 제프리 회장님께서 보다 나은 미래 의료 시스템 구축을 위해서 우리가 좀 개선해야 하는 부분에 대해서도 짚어주셨고요. 또 지속 가능하고 체계적인 의료 시스템 파이프라인에 대해서도 제안을 해주신 것 같습니다.
by 2030. So thank you very much for that meaningful
이어서는
speech.
두 번째 기조연설 청해 듣겠습니다. 다음은
Moving on, we will have the keynote speech from Ms. Salma Jaouni, CEO of the Healthcare Accreditation Council. Let me briefly introduce Ms. Jaouni. The Healthcare Accreditation Council is the only independent non-profit organization in the Arab region that aims to enhance the quality of healthcare and social welfare services. Ms. Jaouni has successfully led the council to become a recognized institution, and today she will present on the topic Key Elements to Universal Health Coverage.
네, 여러분 큰 박수와 함께 무대로 모시겠습니다.
Good morning, everyone. Thank you very much for HIRA and its leadership for inviting me to share with you some insights from the experiences of Jordan and the Healthcare Accreditation Council in how we bring together primary healthcare, or we look at primary healthcare, universal health coverage and quality. It is very hard to follow after our great professor and president of ISQua, Dr. Jeffrey Braithwaite. But I hope I will bring you new insights. As you saw in Jeffrey's slides, one of the 9 elements that are being pushed forward in healthcare these days are related to accreditation. And many countries are trying to adopt this methodology and link it to quality improvement. So how does it work, and how does it support primary healthcare, and does it really, is it really a critical element for universal health coverage, which all of the countries are trying to achieve? So to put it in context, I'm going to just a little bit give you a snapshot of the healthcare system in Jordan so that you can understand why and how we use certain things before I go in it. So Jordan is a country in the Eastern Mediterranean region. It's a relatively small country that currently has 11 million people. But we did not grow that organically. We woke up with an additional 3 to 4 million people in a period of 10 years or 15 years who are in need of healthcare and health sector because of the complicated political issues that are in my region. So we have a large number of refugees, many of them who are not sitting in camps and being looked after by UN agencies, but are actually using our own healthcare and education systems, as well as competing for employment. And they are not babies growing to be adults. Many of them are already adults and are already older and have a lot of requirements. So this is the country that I come from. Even before the growth in the population, our country was, health system is divided into a very complex system. To make let alone healthcare, is very complicated. We make it more complicated by the division of healthcare provision responsibilities into public, private, and not for profit. And in the public sector, the Ministry of Health itself, who is supposed to be the regulator of this system, is actually a provider of healthcare through hospitals and primary healthcare centers. We have other systems that are military, that are private, and some are non-for-profit and more specialized in the care that they give. Prior to the pandemic and with this system, Jordan was faring well on many indicators that are measured by the World Bank and measured by the World Health Organization and reported, whether it is maternal mortality or rate of vaccination, whether it has to do with the health expenditure and so on. We may not have a large number of beds per population, but we were doing relatively well on many indicators. We were not doing well on prevention. So Jordan, even before the pandemic, was spending more than 70% of its healthcare expenditure on treatment, on tertiary, secondary, and tertiary care rather than primary healthcare, which is a challenge in itself. In the slides of Jeffrey, where he also showed aging is an issue, primary health care is critical for all stages of life, from birth until death, whether it is vaccination and mother and health and child, whether it's nutrition, all the way to palliative care. Primary health care is critical to the provision of good health in a dignified and accessible format. Access to care in Jordan is not a problem. Access in terms of finding a primary health care within 15 minutes maximum from your home is not a problem. The fact that you can walk into any public healthcare institution and request a service is also not a problem. Coverage per se is not a problem. So many people misunderstand universal health coverage by only saying that it should be at a low cost from an accessibility perspective and within reach from the population. But we always fail to add the very important component, which is the quality of care. So although we have 750 primary healthcare centers, and we have a strong tertiary care, and we have many, many funding sources. There's civil insurance, there's military insurance, there are university funds, there's private sector insurance, and there's even political funding for the very poor and those who have no type of coverage, okay? And we do have very high expenditure. It is the quality of care that has always challenged the situation in Jordan. What was concerning were two things. At the macro level, the focus of leadership, the availability of human resources, the fact that we don't have a family health system where we can refer people from primary health care to tertiary. A lot of people who have headaches just go to a neurologist. They don't pass through their general practitioner or a family medicine person. And that really, really negatively impacts the quality of healthcare. Guidelines, Jeffrey said 60% of the care we provide is sort of evidence-based or guidelines-based, let alone in a country that does not enforce guidelines as a requirement for the provision of care. That was at the general country level. At the institutional level, whether it's health centers or radiology or laboratories or hospitals, we were challenged with a lot of things related to basic hygiene, waste management, quality control, medication management, emergency care, privacy, human rights, patient-centeredness. And that was very critical when we were really looking at the health sector earlier in 2005, and we were setting the national agenda for 2020. These were pictures, or are pictures, from primary healthcare centers. And they tell you the level of challenges just by looking at them. So I do have access to a primary healthcare center, but is this a safe place for me to go and get my healthcare? Is this the way I want the information documented about me when I use the emergency room? Is it complete? Is it informative? Does it go back to my primary giver? Emergency medicines are not even looked at for access, proper access, and so on. So to address that, Jordan established our company, or our organization, the Healthcare Accreditation Council, which is a beautiful public-private partnership between the government and the private sector, not just to provide accreditation, but to ensure that there is a voice and drive for continuous quality improvement and patient safety. So this is who we are and what we do in partnership with a lot of stakeholders, NGOs, donors, government, health organizations, private sector, because we want safe healthcare, we want quality services, we want to make sure the environment is very supportive and conducive of that, and we want to empower providers because we believe that providers and their skills are what is going to make a difference. So accreditation as a methodology is one of the things we address, but we work on other areas as well. So we provide those services through two very distinct arms. One is an accreditor and the other is an enabler. So we have to enable the environment to make sure that they are able to comply with the standards that are required. So to zoom in on primary healthcare as a very important component of universal health coverage. The 5 core essential public health operations do form for us, when we develop the standards of primary healthcare, the framework that we design those standards from. We look at health protection, disease prevention, how to monitor it, how to promote it, and make sure there is surveillance. And our standards are developed in that way. The HCAC standards and our accreditation methodology are strong drivers for improvement of healthcare. So if you zoom in on the standards, you will see that there are many areas that are critical and were very critical during the pandemic to support the provision of healthcare. Whether it's the facility and its environment, whether it's infection prevention and control, whether it's human resources. And these ingredients were really, really critical. There was a study in Jordan actually done during the pandemic on a number of hospitals, not primary healthcare centers, but it's within the same world. That showed that hospitals that were accredited were more ready to deal with the needs of the pandemic than hospitals that were not accredited, because they had strong infection control programs, they had strong plans in their emergency departments, they had well-developed communication systems, good inventories, and that was very critical for dealing with the pandemic. The content of the standards does not only touch on quality-related requirements for patient-centeredness and safer care, but critical components of universal health coverage, such as governance, community integration, and the continuum of care, let alone the client care or the patient care that is required. this is not easy to achieve. The standards that you saw and compliance to them is not easy to achieve. So there are many ways of helping primary healthcare centers or hospitals to get ready for their accreditation process. But you have to know that you need implementation teams that are not just in your quality department, but that are across your healthcare institutions. You need to make sure that you know what is the vision of the healthcare institution that is providing this care. Capacity building is critical, and documentation, at least in the first round of accreditation, could be very burdening, but it is a platform where you can move into implementation. Without knowing what you need to do and the policies and procedures of things that you have to do, you cannot move into implementation and monitor from a baseline of where you were to where you are in it. The accreditation process actually helps a lot in really being used as a tool for you as a healthcare leader to make sure that your organization is following certain standards in the provision of care. It starts with a self-assessment to understand where your gaps are, the preparation, the accreditation, and the re-accreditation, the fact that you have to do it every 2 years or 3 years or 4 years, whatever the cycles are, makes sure that you are always ready. And there is a paper also published in ISQua's journal, it's a white paper, that shows that accreditation over time is what really impacts the quality of care, from getting ready just for standards to maturing into a culture of quality and continuous provision of services. So, did we make a difference? This is what the research in Jordan shows, and this is what you can look at if this is a tool that you would like to use for improving primary health care, ensuring the quality part in the universal health coverage approach. We said that human resources are very, very, very important. And the studies showed, and those studies are done by third party, not by us, whether they are projects in the field or they are funded by donors who want to understand what's going on. So it shows a lot that there is an improved attitude by the employees and the staff towards quality and quality systems and adhering to that. It also shows that within departments, for example, medical records people have understood the importance of medical records, and this is a lot of data that HIRA collects in order to understand where we are going in certain things. Studies also showed that there is increased and improved patient satisfaction. And if any one of you was at ISQua's conference, you would realize that patient satisfaction was one of the areas that was highly dealt with, and that satisfied patients are more likely to comply with their treatment and comply with what their providers are telling them, so that you have a more successful treatment path. We have showed as well that for the couple years program, there is improved compliance to family planning in accredited versus non-accredited primary healthcare centers, and we have even touched or were able to improve diabetes control and hypertension control from a public health perspective. This were stronger and better addressed in accredited versus non-accredited primary healthcare centers. If you see in this slide the importance of the pre and post evaluation when you do your own gap analysis, and then when someone comes and looks at you and tells you where you are. You will see that our primary healthcare centers were very, very limited in their compliance to standards, whatever those standards are, and that the accreditation process is what pushed them towards better provision of care. And those are related, could be related to integration of standards, and especially in primary healthcare, community has a very important role in designing the health services that you need. And this is what universal health coverage also preaches, the importance of the involvement of the communities. Referral, we talked about that. When you have a weak referral system, the losses of patients and their needs is humongous. So we looked at primary healthcare centers that are accredited and those that are not, and we were able to show as well that there is improvement in the referral systems. The World Bank did a couple of studies in Jordan, not necessarily addressed at accreditation. They were looking at quality of care, and they were looking at equity, and they were looking at the voice of the patients. And some of those studies were on primary health care, and others were on primary health care and schools. So they were combined studies. Towards universal health coverage, there was a comprehensive review of the health financing system in Jordan done by the World Bank, and it showed that just the fact that you are preparing your institutions for accreditation, there is substantive quality improvements such as better medical records, more effective human resource practices, oversight of equipment and consumables as part of the requirements, among other outcomes. Also, that accreditation actually catalyzed the community input and engagement, which is critical in primary healthcare in specific, but it is critical across all provisions of healthcare, as we've heard in the ISQua conference, and specifically now that we are trying to drive a lot of our work towards co-production. 74% of a sample showed that the total standards affecting quality of services increased and improved with employee satisfaction, and it was affecting employees' ability to be retained in those organizations and decreased the turnover. Another study from the World Bank that looked at the Middle East and North Africa also showed that accreditation is generating multidimensional approaches towards the culture of quality. It instigates formalized opportunities between patients and staff members. So if you didn't have it and you didn't connect with it, it happens just because you are planning to go towards accreditation. It remains after the accreditation is completed. Accreditation standards also support the voice of both the employees and the patients, because it's a requirement to make sure that they are informed, that they consent for what's doing, that you have those conversations with them. It also pushes the clinical effort of provider. The study showed that in accredited facilities, providers actually spend more time on average with the patients than in centers that were not accredited. And the p-value in this was very critical and quite interesting. So this is how Jordan decided to move forward in pushing its quality agenda. From the success stories of accreditation, it decided, for example, today it's enrolling 300 primary healthcare centers in getting them towards the accreditation. And with that tool, they are identifying the gaps that they have, and they are trying to push the resources or find the resources in a very scientific way to cover those gaps. But accreditation alone is not a magic tool or a magic wand. It has to be complemented by many other things. Clinical guidelines, the professionals and their ability to provide what are the skills that we need. Are they getting them in the medical education tracks? Are they being trained properly? Are they maintaining their training and making sure their skills are always up to date? Regulation is very important, and data measurement and health outcomes, which this circle for me has an X, because in Jordan, unfortunately, we do not have that. And I may have had conversations with Dr. Ham from HIRA about how we can learn from you along those lines. We are trying to move forward. We have a new plan for 2030. It's called the Economic Modernization Vision. And you will see that the 6 critical areas in it are moving towards prioritizing and activating primary healthcare and moving towards the family health model, improving quality based on indicators, and strengthening the human resources is very, very critical. Thank you so much. I hope I was able to share with you how we used accreditation as a tool for quality improvement in support of achieving universal health coverage. And I am, like Jeffrey, here for the rest of the day, very much willing to answer any questions and have any conversations with you that hopefully would be meaningful to both of us. And enjoy your day. Thank you very much again for having me here.
네, 여러분 큰 박수 부탁드리겠습니다. 고맙습니다.
Thank you so
보편적
much for
의료
your
보장뿐 아니라 의료질 개선에 있어서
Not
필요한
only about
부분에
the universal
대해서
health coverage, but
요르단의
also about
삶과
quality
함께
of
또
care.
중요한 강연을 해주셨습니다.
Ms. Jaouni
다시
shared a
한번
case of
감사의
Jordan
인사드리겠습니다.
and shared her
여러분,
insights. Thank you
이것으로
very
저희가
much.
준비한 오전 세션은 여기서 마무리가 됩니다.
So this wraps up the morning session, and now we will have lunch and we will resume at 1:30.
운영요원의 안내에 따라서 오찬장으로
We ask our distinguished guests to follow the guidance of staff as they will guide you to the luncheon hall, and for on-site participants, we kindly ask you to please enjoy your lunch at the COEX Starfield Mall B1 using the meal vouchers distributed beforehand. Also, please refer to the conference booklet for available dining options and details. And for the interpretation receivers, please return them as you exit the hall to prevent any chances of losing the receivers. We will distribute them once again before the afternoon sessions.
오찬을 즐기신 후 같은 곳에서 1시 반부터 저희 오후 세션 시작하겠습니다. 여러분 식사 맛있게 하시고요. 다시 인사드리겠습니다. Ladies and gentlemen, now we will have a lunch time. Please enjoy your lunch time and please come back to this hall by 1:30, or better yet to come back to this hall 5 minutes prior to the commencement. Thank you very much for your attendance and see you at the afternoon sessions. 네, 여러분 식사 맛있게 하십시오. 고맙습니다.
조명 감독님, 죄송한데 패널 거 조명으로 한 번만 바꿔주시겠어요? 패널리스트 조명으로 한 번만 켜주세요.
네, 여러분 잠시 안내 말씀드리겠습니다. 네, 저희 국제심포지엄 오후 세션 잠시 후 시작이 될 예정입니다. 저희가 약속드린 시간은 1시 반인데요. 지금 몇 분 남았습니다만 장내로 서둘러 좀 입장을 해주시고 저희가 원활하게 또 생중계와 현장 진행을 할 수 있도록 협조해 주시면 고맙겠습니다. 또 오전에 했던 것처럼 동시 통역 서비스 제공합니다.
Just like in the
한국어
morning, we
1번이고요.
provide interpretation
영어는
service.
2번인데요.
Korean is
혹시
for
아직
1 and
리시버
English
가지고
is
오지
for
않으신
2.
분께서는 받으신 곳에서 오전에 받으셨던
You can get your
곳에서
receivers where you
꼭
got it in the
수령해서
morning,
착석해
so please make
주시길
sure
부탁드리겠습니다.
to
여러분 저희 잠시 후
take it with you.
시작하겠습니다.
We
고맙습니다.
will begin in a short while. Thank you very much.
네, 여러분 다시 한번 안내 말씀드리겠습니다. 네, 저희 오후 세션이
Some
잠시 후
housekeeping
시작될
notes once
예정입니다.
again. Our afternoon session will begin in a short
건강보험심사평가원
while.
함께해주실 분들께서는
For those of you
장례
here for the
입장해
2023
주시길
HIRA International
부탁드리겠습니다.
Symposium, please
Distinguished
be
guests and
seated.
ladies and gentlemen, will soon commence the afternoon sessions of the 2023 HIRA International Symposium. Please enter the hall and please be seated. And as we did before, please use your receivers for any interpretation service. Channel 1 for Korean and Channel 2 will be for English. Thank you. Distinguished guests and ladies and gentlemen, welcome back to the afternoon sessions of the 2023 HIRA International Symposium. As we did at the morning sessions, we do have simultaneous interpretation service throughout the sessions. So please use your receivers, channel 1 for Korean and channel 2 for English. 네, 여러분 다시 인사드리겠습니다. 식사는 좀 맛있게 하셨나요? 네, 고맙습니다. 현장에 계신 분들
I hope you
다시
have all
발석해 주셨고요.
enjoyed
또
your
멀리서 나와
meals.
많은 시청자 여러분께서
I'd like to thank all of our online and
계시는데,
offline
네, 그럼
participants
지금부터
for
오후
being here.
세션
So now let
준비된
us
시간을
commence the
소개해드리겠습니다.
afternoon
세션
sessions.
1에서는 북미와 유럽의
In the
사례를
first
나눌
session, we
예정이고요.
will delve into
세션
cases from
2에서는
North America and
아시아의
Europe, and in
사례를
session
통해서
2, we will highlight
통합지구
Asian
세계 변화를
cases.
위한 미래 보건
And we
의료
will
시스템
discuss how to
구비에
prepare
대해서
for future
노하우와
healthcare
더
systems
많은
by
도움을
strengthening the
주시길
integrated
바라겠습니다.
healthcare
여러분
system.
끝나는 시간까지 함께해 주시면
Please stay with
고맙겠습니다.
us until the
저희는
very
모든
end.
발표가 끝난 이후에
And
오늘
once
심포지엄의
we are
마지막
done with all of
순서인
the presentations, we will have a panel discussion.
자, 그럼 세션 1의 첫 번째 연사를
So
소개해드릴
the
텐데요.
first
첫 번째
speaker for
연사는
session
조엘
1 is
루이스,
Mr. Joel A. Roos, the Vice
국제인증평가위원회
President of Joint
부회장님께서
Commission
소개해
International.
주시겠습니다. 잠시 좀 소개를 드릴 텐데요.
Let me briefly
루이스
introduce
부회장님은요,
him.
국제의료기관 평가위원회에서 새로운 국제인증
The
표준
Joint
개발,
Commission
그리고
International is an
인증
institution
프로세스
dedicated to
개선을 위한
enhancing the
노력을
quality of health
주관하고
and patient
오늘은
safety. And today, the Vice Chairman Joel Ruth will be talking about the future of healthcare system, ensuring healthcare quality and patient safety. Please welcome him with a big round of applause.
Good afternoon. First of all, thank you very much for the kind invitation to speak today. I am very honored to be here. I also would like to, thank everyone for the most difficult task of the day, which is giving the first presentation after a wonderful lunch. So it will be a extra challenge to make sure that I keep everybody interested and awake. So I am Dr. Joel Roos, the Vice President of International Accreditation for Joint Commission International. And by way of my background, I'm an emergency physician and a senior healthcare executive with a number of different experiences. And today what I want to talk about is really a extenuation or extension of the integrated healthcare system that we're starting to talk about. Probably in some ways the most extreme extension, but hopefully a little interesting as we look at technology and where things are going, and also touch on the role of accreditation as a quality and safety process in this. So I'm going to talk about some global trends, the implications for both patients and the providers, the impact on quality and patient safety, and then I'll hopefully leave you with some key thoughts at the end. You all know that healthcare is changing, and it's changing very quickly in a number of fronts. COVID has really pushed this change, accelerated this change. We're seeing changes in the area of technology and its rapid adoption. Digital health records, remote monitoring, artificial intelligence, point-of-care diagnosis, portable medical equipment. All of these are enabling care to be delivered differently, faster, and in a variety of settings that we haven't delivered care before. We're seeing a rise in telehealth, as we all saw during COVID, virtual consultations, remote technologies, all have really gained significance over the last couple of years. They were being developed, they were being used, but we've really accelerated that advancement. Healthcare IT, we're used to electronic medical records, but now we have patients' ability to access their records remotely, many by their smartphones or tablets. The data that we are collecting, artificial intelligence, natural language processing, all of these are changing how we operate. Mobile health. How many of you have a smartwatch? Right? Samsung or iWatch, that's a mobile health device, whether we think of it in those terms or not. It's one of many. You can track your blood oxygen levels. You can look at, it'll track your EKG and warm for atrial fibrillation or abnormal rhythms. This is one of many. There are many sophisticated technologies that are out there. Well, all of this is leading to a change in how we deliver healthcare. And then there are things such as the mobile clinics. We are used to thinking of going to the doctor or going to the hospital, but now we're starting to bring the hospital or the care to home. The emergence of dialysis vans, dental vans, other forms of portable healthcare and delivery. We're seeing an increased push to home-based care. More and more care is delivered in the home, whether it's visiting nurses and or other sorts of providers. For example, in the US, my father-in-law is now living with. He's 96. We have a nurse. He gets nursing care twice a week. He gets a health tech visit twice a week. And we have a teleconsultation with his provider every so often. We are seeing an increased emphasis on value-based care. The idea that We're really focused on outcomes and ensuring that we're getting the best value of care or the best quality of care for the money we spend. And it doesn't matter what country and what currency we're using. This trend is accelerating as it should, because medicine is expensive. It doesn't matter where you are. And as you heard before, we're focusing more and more on preventive health and population health, public health and global health. All of these terms, it's no longer just about the individual patients, but what can we do for society? What can we do to prevent illness from occurring? And there's more emphasis as we gain more knowledge. And then finally, sort of the focus of not only my talk, but really the symposium in general, is integrated care delivery, whether it's throughout the healthcare system, with integrating the primary care, the specialty care, behavioral health, and social services. All of these, aim to provide a coordinated set of services and care for patients in a much more holistic fashion. So with that, and one of the most interesting trends is hospital care is shifting. The hospital as we know it is changing, and it's an interesting dynamic. The actual physical hospital will become reserved for really specialized care of really sick patients. The idea of coming into the hospital for lengths of time has slowly changed as technology has changed and as knowledge has changed. But as a perfect example, I'm a little older than most people in the room. When I started medical school and you went in and had your gallbladder removed, that was an open procedure. You were in the hospital for a week as they, waited to make sure you didn't have infection, you healed, you had to wait for your return of motility of your gastrointestinal tract. And so what was, it was a long operation and a long stay. Now it's a same-day procedure. You're in, you have the laparoscopic surgery, and for the most part, you can go home within 24 hours. That's just one example of how technology and knowledge is shifting, but more and more, as we saw during COVID, we were reserving hospital beds for the really sick. And as a result, patients' homes will become the hospital of the future as we use more and more technology to deliver and monitor that care. But key to this whole process, if we're going to move patients from the hospital to the home, i.e. the hospital without walls, then integration of that care is going to be really important, in addition to partially to ensure the quality, the safety, and the outcomes. And then lastly, for any of this transition is all dependent on the ongoing digital revolution that I mentioned earlier. So what does this mean for the patients and the providers? I'm going to give you two examples. They're actually relatively basic. There are much more complicated medical examples I could share that have been done, but these are sort of give you an idea of where we're going in medicine. So in this case, our first patient, she's a 75-year-old woman who lives at home with an elderly husband that she cares for. And she's admitted to the hospital for a heart attack or an acute myocardial infarction. Typical care is you get your inpatient care, you get your testing done. If you need procedures for stenting or the like to reestablish cardiac function. But typically, and very often in the United States, from there you go to a skilled nursing facility. You don't go home. You go and have additional care and rehab that's supervised. And but the same token is, I mentioned she was the caregiver for her husband, and now we have a social issue as well. Now imagine a future state that's already happening and underway. This is not so far off, is instead of going to a skilled nursing facility after the same treatment, your patient is discharged to home with a nurse. Regular nursing visits at the home, come check in on the patient. You also can configure the home for remote monitoring, not only for wireless cardiac monitoring, blood pressure. You have remote cameras, so you can actually see them walk around the house. You can have sensors if patients should fall. And so you can really change the setting within the home. In addition, you have regular physician visits that can be done by telemedicine. Same with different types of providers. The medications are delivered to home, no going to the pharmacy. Oh, by the way, we deliver medications now in certain areas with drones. Again, one more use of technology to bring care to the home instead of remaining in the home. And then, of course, you can have meals delivered as well to ensure appropriate nutritional guidance, both for the patient and her spouse. So it's a very different set of models of where we're going. And again, this is one example, and I'll share one more. So in this case, we have a 65-year-old gentleman who's previously active, but he has chronic right hip pain and basically had a hip replacement or a THA. Typical care is get it replaced, discharged to home after with 4+ weeks of home-based physical therapy. You come back to the office periodically, get seen, but there's really limited coordination between the orthopedic physician who's taking care of the hip with the primary care physician who may be managing multiple other things like cholesterol and heart disease and hypertension, and also the physical therapist. How does that get coordinated now? It's somewhat difficult. And there's really no remote monitoring of what's happening at home or additional supervision of the rehabilitation. Imagine a future state, which again, not very far off in the future, some of these things are already being done. The trend is just going to accelerate, where again, same surgery, discharge at home, in this case with a comprehensive plan that includes electronic guided rehab. Patients are receiving their rehabilitation with essentially video games that can be controlled and reprogrammed as a remote service. In addition, the physical therapist can do far more frequent assessments via telehealth services. And in addition, the primary care physician can remain involved and coordinate this care to see how they're doing with their other medical problems, rather than requiring the patient to come into the house. Patient coming to the hospital. And then again, we see the opportunity to coordinate care better. These are relatively simple scenarios. There are others that have been done with much sicker patients where the hospital really has moved to the home, and you have more frequent nursing care. You also have to train the family to provide some semblance of nursing care. And so more and more, we're seeing the hospital moved to the home. Now, there's some significant implications to the providers, both good and bad. From the opportunities as a physician, we can really provide patient-centered care. The idea that you're receiving your care in the home, you're not in a hospital, it's uncomfortable, you don't get sleep, the nurse is always interrupting you, we sort of know that scenario. In addition, there's the patient engagement and empowerment of being in their own environment that accelerates healing and is much more conducive just to feeling better. You can personalize care in this manner where it's not one size fits all, it's easier. You can increase accessibility if you happen to live far from a hospital. It's very difficult to go to and from. I mean, even in Seoul, where you may be close, the traffic may make it much of a longer trip than necessary. So the idea that you don't have to go into the hospital for care is better, and you can have your family around you. The idea that you can intervene early, you can do preventive care, you can do population health management, and more importantly, there's opportunities to leverage all this data we're collecting with these sensors and other information. So many other opportunities that are great that come from moving the hospital home. There are also some challenges that come along with that. You have to really be vigilant, and that's really the point of where we'll move, of ensuring that outcomes and quality and safety remain consistent. There's tremendous opportunity to fragment care, where even though we have this technology where providers still don't communicate with each other. Again, ensuring the standardization. Sending patients home instead of the hospital, even though hospitals are dangerous places for falls and infection risk and things like that, homes are dangerous too because they're not designed potentially for a patient with a walker or crutches or having monitors. And then there's skills and training. I mean, if I were to suddenly go home and expect my wife to care for me with no medical training, what is the expectation of the family members in this sort of environment? So we have to ensure that there's some level of training that's standardized when we move patients to the home. And then, of course, patient privacy with data collection and ensuring that we're now very dependent on these electronic devices, ensuring that they remain operational the whole time. So 24/7 operation. So let's talk a little bit about ensuring the quality and patient safety, which is really the point of combining these two topics, is how do we do that, or what are some of the tools available? So, there are tremendous opportunities given these dynamics, and in order to seize these opportunities and addressing the challenges, we must focus on quality of the care delivered and the patient safety. And this is essential if we really want to integrate this care from the hospital all the way to the home. So some key factors to consider when we do this are the adoption of evidence-based standards and best practices to maintain the consistency of the care that's delivered, proactively reducing the errors and preventing the harm for staff, patients, and the caregivers. When a hospital is extending beyond the traditional walls, it is essential that the same level of safety is maintained across this continuum. We have to ensure that the care is coordinated and that there's communication, that the quality requires continual improvement, and so the discussions you heard earlier today on continuous quality improvement is paramount here as well. It doesn't change because we've moved. In some ways, it's become more important. We need to maintain the trust of patients when we do this and their families. So we have to focus on building that trust. And then last and near and dear to my heart, but not least, is the objective validation of the quality of this care through accreditation. As we've heard earlier, accreditation sets the foundation and enables quality of care. It creates a culture of safety. It is a foundational tool to ensure quality of care in a hospital setting, and that doesn't change because we've moved the hospital to the home. So interestingly enough, we talked about the benefits of accreditation and how it's used, but we really didn't define it. So I thought I'd take a moment to really take a stab at defining what is accreditation, which is really determination by a third-party organization that an eligible program, institution, or an organization such as healthcare, but it doesn't necessarily, it applies to other settings other than healthcare organizations, complies with a set of standards indicating a quality or level of performance has been achieved by a independent third party. Basically, somebody's comparing you to a standard, and I'll highlight that a little bit more. But that's fundamentally what it is. Doing it is a whole different discussion. So let me go. So really, accreditation consists of two components. The set of standards, which define the expectations based on evidence. These, when we start talking about accreditation and standards, it's not something we're making up. It's not some ideal that, we really want the hospital to look this way, or we want safety to look in such a way. It is based on research and evidence. And that's a key fact. So that's why it requires a lot of work. And then the actual survey or the measurement is measuring the performance of the organization, whatever type of industry we're in, against these standards. Again, it sounds simple when I describe it this way, but developing standards is really difficult. And the survey is the key, and the surveyors are really the art. This is where the art and the science meet in my mind. So obviously I'm from Joint Commission International. Why us? We are the largest international accreditor. And I say international, that we're operating in, at the moment, 73 different countries and numerous organizations and program. But we've been doing this for a long time, and evidence has shown, as you heard earlier before, that the accreditation process really drives excellence, drives quality outcomes, And we do this through establishing the mindset and the culture around quality and patient safety, leading to increase in standardization. We lower the risks associated with healthcare. It's still dangerous. And then at the end of the day, improving the quality and the patient safety for everybody that comes through the facilities. There are lots of accreditation bodies out there. I'm not going to, and serving different purposes. You have, in many cases, national accreditors, as in here in Korea or Japan locally, where the focus is on the country with country-based standards and the like. And then you have international accreditors such as ourselves. And it's not a matter of one better than the other, and that's not my purpose. There are differences associated with them, which has to do with a number of factors. And these are the things you should look at if you're choosing accreditation or want to understand the differences among organizations, which is what are the standards, how many different types of programs that they offer, or what, right now I'm focused on the hospital itself, but if you'll see in a minute, there's other opportunities for accreditation. To me, the most important part, in addition to the standards I highlighted, is the surveyors and the process. But also, what other resources are available in terms of learning, references, and educate, in terms of helping organizations not only achieve accreditation, but maintain accreditation. Is there ability to benchmark performance? Can we collect data and show, the goal is not to show one organization is better than the other. That's not the purpose of benchmarking. Although we'll admit that medicine is a competitive business, hospitals want to attract patients. One way you do that demonstrates through benchmark. That's not why we do it. The goal is if somebody's doing something better than you and you see that you are motivated to, we can improve our numbers then too. Perhaps you reach out to these organizations or you ask for help elsewhere. But benchmarking shows what's capable and where you stand against that. Obviously, like any other form of data, it can be used for other purposes. Oops. So I mentioned when you look at accreditation, there are accreditations for different settings. And in this case, these are some of the settings that JCI operates in. We have the hospital and academic medical centers, ambulatory care, laboratory, home care, long-term care. You can read these telehealth, enterprise, which is really organization-based, and then medical transport and primary care. Interestingly enough, if we start talking about the hospital without walls, it doesn't fit one of these categories. It is an integration of multiple aspects of these applications. So as I look to the future and develop a accreditation program for truly the home hospital, it's going to contain elements of hospital care. It's going to contain elements of ambulatory, home care, perhaps long-term care. Telehealth standards will be included. But the one we haven't really talked about is medical transport. We've talked about getting a patient from the hospital, the traditional hospital, into the home. But part of the quality process and the safety process is ensuring how do you get a patient out of the home, what are the indications for, and that sort of mindset. As an emergency physician, my mind is always on something. If it can go wrong, it's going to happen when I'm working, and I'm always trying to think a step ahead of what it is. So when we look at the hospital without walls going into the future, and there, as I said before, there's some very sophisticated examples out there that approach almost ICU level care. Accreditation is going to need to account for a number of these areas because it's really a new form of a hospital. I briefly want to just touch about what's different about those 10 categories I just showed you. I mean, they're all accreditation, they're all around medicine. How are they similar and how are they different? As you saw earlier this morning, they're basic pillars of what accreditation includes, which is elements of medication management, infection control. Those are foundational. It doesn't matter who set a standards and what accrediting agency. So on the left side of the screen, you'll see basic categories universal to any accreditation, both program or in this case setting, as I define it, whether it's governance, quality and safety standards, emphasis on patient-centered care, patient rights and the like. On the right side are some of the areas that are specific to an individual program that may differ. What makes a particular setting eligible for a accreditation? Requirements for infrastructure. Requirements for a laboratory accreditation would be different from a home care setting or an ambulatory care setting. That type of infrastructure, in addition to perhaps patient record or recording of collection of information. How care is delivered in these settings are clearly different. Excuse me. The population of patients served in these various environments are different. So this standards will account for these differences and also the similarities. So it's always interesting because I don't write the standards. I have experts that do that, and I look at them and say, so what makes these two programs different? Because they seem really similar to me. And these are the key, both similarities and differences that go into creating the standards, and subsequently the programs. So, just to summarize, the focus on patient-centered care and the advances in technology, and combined with the forcing function of COVID, are really transforming healthcare for the better, in my mind. The hospital without walls is really the future of healthcare. In some places it's going to go very quickly, some places it's happening, and other places it'll happen over time. I would suggest in Asia, where there's tremendous amount of technology everywhere you turn, you just have to walk through through the streets of Seoul and you can't miss it, that the technology is rapidly advancing and available. There's clearly some places around the globe that's not the case. But this future of the hospital without walls really has lots of opportunities, but also comes with challenges, and particularly on patient safety and quality, and that focus and that emphasis on really looking at how we're doing things becomes more important, not less important, because we're out of the watchful eye of lots of nurses in a hospital or lots of doctors rounding and all the infrastructure. So that really focusing on safe delivery becomes that much more important. And finally, I highlight JCI accreditation, but in fairness, all accreditation is paramount to ensuring this quality and patient safety as we make this transition over time, because the world is changing. Thank you.
네, 발표 잘
Thank you very
들었습니다.
much for your
귀한 발표 준비해
presentation.
주셔서 진심으로 고맙습니다.
Thank you very much once
부회장님께서
again.
미래의 기술과 또
So Vice President
새로운
touched
기술에 따라서
upon
환자의
how
안전을 확보하는 동시에
it's very important to
의료진을 향상할 수 있는
ensure
시스템에 대한 사례를
quality of care as
들어주셨는데요.
well as
다시
patient
한번
safety
귀한
going
강연
forward
준비해
with the
주신
various
부회장님께
transformations. I'd like to
감사
thank the
인사드리겠습니다.
Vice President once
자,
again for his
이어서는 첫 번째
presentation.
세션의 두 번째 발표 청해 듣겠습니다.
Moving on, we have
앤서니
Dr. Anthony
스테인스,
Staines,
보병원
Director of the
연합
Hospital Federation of BOD,
프로그램장님께서
who will
준비해
present
주셨고요. 현재 프로그램장님께서는 스위스
Next.
보병원 연합에서
Dr.
환자
Staines
안전 개선 프로그램을 운영하고
is
계시고
leading
또 환자
patient
안전
safety
전략에
improvement
대해서
programs at
여러
the Hospital
경험을
Federation of BOD in
조언해
Switzerland
주시는 업무도
and provides
담당하고
advisory
계시다고 합니다.
services on patient
오늘은
safety strategies
의료진과
to various
환자
hospitals.
안전 개선
Today, he will
방법,
present on the
스위스
topic
사례를
approaches to
중심으로
higher quality and
라는
patient
주제로
safety,
준비해
the case of
주셨다고
Switzerland.
하는데요. 네, 무대로 등단을 해주셨고요.
Let's now welcome
여러분 큰
Dr.
박수로
Staines.
맞이해 주십시오.
Very much. My role is to introduce you to the case of Switzerland about quality and safety in healthcare. So I brought you two pictures from Switzerland. You can see a mountain, the Matterhorn. Switzerland is a very small country. It's a population of 8.7 million, so less than the city of Seoul. And it's divided into 26 different cantons, and health is run by the cantons, not by the federal state. We have 4 languages in Switzerland, in a small country, and high healthcare costs. We have good health indicators in Switzerland. We have high life expectancy, low avoidable mortality, 100% coverage in terms of health insurance, so universal coverage. And as I said, we're a costly country, second to the United States. So this leads to a challenge for quality and safety in healthcare. You may say, well, you have good health indicators, so it's an indication that you have a good healthcare system, and that's what the majority of the population believes, the politicians believe, the healthcare community believes, and it's of course, you are health experts, so you know that there is confusion in that reasoning, because the good healthcare indicators do not come. They probably the healthcare system plays a 10% role, a 10% determinant of good health indicators. The 90 other % are good housing, good revenue, good education, and because of that, it's a challenge to improve healthcare in Switzerland. Because people believe it's already very good, so if it isn't broke, don't fix it. So because of that, the Swiss government asked for an analysis and a status of quality and safety in healthcare in 2019, and I was privileged to team up with Charles Vincent from the University of Oxford to do that assessment. And here you have a one-page summary of the report. So first of all, little is known about the standards of healthcare in Switzerland. We don't measure as much as many other countries do. We have limited knowledge about the quality of our healthcare system. From the limited available information that we have, we can conclude that healthcare is probably comparable to other European countries, but according to how much more we spend, which should be much better. We're probably average. There are some well-developed and effective national monitoring systems, but and Switzerland has made some important steps in the journey towards a more just and human approach for those affected by medical errors. However, the policies and the results vary widely by region and by cantons. There are valuable programs in place in Switzerland, but education and training in quality and safety need to address all professional groups. And the Swiss healthcare is very complex, difficult for people to understand, and there are many inconsistencies because of a fragmented system. We are really not an integrated system. And boards of trustees of organizations, healthcare organizations, need to allocate much more time and priority. The financial well-being of the healthcare institutions is often on the agenda of boards. Quality and safety is not very often on the agenda. So that's the basic situation of quality and healthcare in Switzerland. So this led to 8 types of recommendations, and I won't go into the detail of these. Some of my colleagues have spoken of some of these topics already up to now. What I would like to focus on is the current effort of one region. It's the region I come from, which is the western part of Switzerland, the part in red on the map, to try to impact healthcare outcomes in hospitals with efficient quality and safety improvement programs. So I'm not saying that this region is better than any other, but it's really trying to influence outcomes for patients. The methodology, we've tried many things, and the methodology that we are currently using is called the Breakthrough Collaborative. It has been proposed by Institute for Healthcare Improvement in the United States, and it's designed to spread evidence-based practices. So the first step is to carry out a literature review to find out what are the models that exist and the evidence-based recommendations that exist. With that, you define an improvement package and a measurement strategy. Then you gather teams from a range of institutions. Our Federation of Hospitals includes 12 hospitals, so usually we would have 6, 7, 8, 9 or 10 institutions joining a collaborative. Then teams from the different hospitals are briefed on the improvement package, on the improvement interventions. Then the interventions are implemented in the hospitals, and the organizers of the collaborative gather the teams every 3 months, and the general principle is that all teach, all learn. So there is an exchange of experience between the different hospitals who share a common goal of improving outcomes on a given topic. So here you have the explanation of the Breakthrough Collaborative. The square boxes are learning sessions. These occur every 3 months. Ahead of time, teams are invited to participate. They have some preparatory work to do. And the organizers of the collaborative do the literature review, identify and invite experts, and develop models, improvement interventions. And between all of the learning sessions, the plan, do, study, act cycles occur in all of the hospitals, in all of the wards, and at the sessions, hospitals compare results and exchange ideas about how they did the implementation. So it's a repeat use of the PDSA, starting in often one ward to test the improvement, and if the improvement works, it's done on a larger scale until system-wide change and implementation. So something important in the organization is the selection of the team. So the teams, so all hospitals in the federation get an invitation that is sent to the CEO, and the hospitals have to decide whether they want to participate or not. We don't want hospitals to participate just because they belong to the federation. We want motivated hospitals and committed management teams. So the hospital management has to commit to certain principles. One is to support the project, including a member of the executive board in the steering committee. They have to appoint a team that will attend the meetings and look after implementation within the institution. And they have to grant the team the time that is needed for implementation, so to guarantee resources. And they have to measure using the indicators of the collaborative, and they have to be transparent within the collaborative about their results. So I believe the best thing to introduce you to that methodology is to show you 2 examples. And I will show you one example of a collaborative that we did in that Federation of Hospitals on hand hygiene, improving hand hygiene, and the second on reducing pressure ulcers. The name Breakthrough Collaborative means we don't try, if we try to reduce pressure ulcers, we don't try to reduce pressure ulcers by 4 or 5%. It means cutting pressure ulcers in half, for instance. So that's the idea of breakthrough. So the first example is an example about hand hygiene. So the strategy that we used is the WHO strategy, meaning a system change from hand washing to hand hygiene using alcohol-based hand rubs. The second item of the strategy is training and education. The third is evaluation and feedback, so observing hand hygiene and measuring compliance and feeding that back to the staff. Reminders in the workplace, we could call that social marketing of the program, and the institutional safety climate. So we use multimodal strategies. I believe all of these 5 items are important, but if you do just 1 or 2 of all of this, it may not lead to really transformational change. Whereas if you do all 5 of them together, I think you can obtain transformational change. The second item is the model that we used. So what we aim for is compliance to the 5 moments of hand hygiene, and you probably know these 5 moments from WHO. Second, this needs a measurement strategy. So you have here indicators. In blue, there are structural indicators. In green, process indicators. And in red or in orange, outcomes indicators. So all of the 5 elements of the strategies have indicators to monitor whether we're taking the right direction in the program. At the beginning of the program, there was a baseline of compliance through observers, and also questionnaires to the staff about their perception of hand hygiene. So you can see the first 3 bars in the histogram, which is the situation before the collaborative started. We asked through a questionnaire healthcare workers what they thought their compliance to hand hygiene was, and their answer is 86%. 20 questions later in the questionnaire, when they have forgotten the first question, we asked them, what is the compliance of your colleagues? And the answer was 75%. Of course, these 2 numbers should be aligned. But it means that people believe they're better than their colleagues. And when we sent out observers of hand hygiene compliance, the actual rate was 62%, and that could be slightly overestimated because the observer was visible, so perhaps people adjusted their practice to the fact that the observer was there. The 3 next bars are after the collaborative, and you can see that hand hygiene has risen to 86%, measured by external observers, and people still believe they have 87% compliance, and they trust their colleagues more, and this is probably a healthier, more balanced situation after the collaborative. So to illustrate what we did on the 5 elements of the strategy, first of all, system change. Well, that consisted in using human factors and ergonomics in hand hygiene, mainly in where we situated the alcoholic hand rub distributors. And our general principle was to have 1 per bed and not 1 per room. And so it means also measurement. And here you have the situation at the beginning of the collaborative, that's the baseline, and you see that about 45% of beds have distributors, and the situation middle of the collaborative and the situation at the end of the collaborative. Of course, this illustrates that we have still progress to make, but it also shows that change is happening. The second item of the strategy was education, so a concept for hand hygiene education, and not only physical workshops on hand hygiene, but also an e-learning tool, both for physicians and for other healthcare professionals, mainly nurses. So also measurement. We asked people if they had continuous education on hand hygiene in the past 3 years, and you can see the progress between the beginning and the end of the collaborative. Still work to do. Assessment and feedback, that's something very important. I believe that's the biggest driver of change in our program. So you can see on the left of the screen the form that we used to assess hand hygiene. The form was then scanned, and that helped build the indicators. And you can see on the right of the screen all the different wards in one hospital with benchmarking of hand hygiene compliance. and that was fed back to the staff every 2 months. And I believe this feedback, when it happens in the ward and where people are associated to studying the results and doing their PDSA, discovering the results, reflecting on where they want to be in the next 2 months and how they're going to get there, what they're going to change, what they're going to improve, I think that's really the engine of quality improvement. It means that for that, the feedback has to really be provided to the teams. And so we asked the teams if they had received their feedback. We want everything to be in green on that chart. And you can see from the beginning of the collaborative to the end of the collaborative, the progress in terms of truly feeding back the results to the staff in the hospital. Of course, reminders about hand hygiene, we call that the talking walls, posters on the walls, for instance, or badges worn by the staff. And this has to be accompanied by a change in leadership and culture. So leaders have to show people what to do. They have to walk the talk in terms of hand hygiene. And we encouraged executive leaders to go to the wards that had reached the goal of 85% hand hygiene and to provide a certificate to show the support of leadership in the wards. So what about the results? You can see that our first audit in terms of compliance was audit 0, which was the baseline, and we started with 62% hand hygiene, which was a shock for institutions in Switzerland because Switzerland believes to be the country of cleanliness. But when measured with rigorous standards, we were only at 62%, and we ended the program at 88% after 18 months of work, after 9 observation periods. Did the change happen in all of the hospitals? There you have the 5 hospitals that worked in this, that participated in this collaborative, and you can see that the improvement happened everywhere. It also happened in all of the professions, healthcare professions, not only for nursing, for instance, but also for radiology, physiotherapists, physicians. Did the improvement happen for all of the moments of hand hygiene? Yes, they did. You can see that on the chart here. And now I want to show you just a little snapshot on the second breakthrough collaborative that we used, the one on reducing pressure ulcers. So we used a driver diagram, and you can see on the left of the screen our goal, reducing nosocomial pressure ulcers by 50%. Then primary drivers are the modes of our multimodal strategy, and the secondary drivers are the PDSAs, the actions that we want to introduce to change the primary drivers, contributing to the overall aim. So in terms of measurement, our core measure was using a safety calendar. You have an example of the safety calendar on the left of the screen. So we asked all of the wards, all of the teams in the different wards to color the day of the month in red if there was a non-present on admission pressure ulcer acquired in the ward. In blue, if it was present on admission pressure ulcer, and in green, the days without pressure ulcers. And this was combined, all of these calendars were scanned, and this was then converted into a chart like you see on the right of the screen with all of the months over an 18-month period, which was the total time of the collaborative, and the goal was to reduce the days in red by half. You can see here a second indicator, which was we wanted assessment of pressure ulcer risk to happen. Two types of assessments using the Braden scale was one of them. That's the part in the dark blue. And in light blue, it's the clinical assessment, clinical judgment of the risk of pressure ulcers within 6 hours, and the Braden scale within 24 hours. So that's compliance to that along the collaborative. Here again, we have still a lot of work to do. We should be at 100%. We are not. But still, this improvement allowed us to reach 50% reduction in pressure ulcers. So you can see here the results, and you can see we started with 8.2% of the days with a pressure ulcer acquired within the ward, and we moved that down to 4.1% of the days with a pressure ulcer acquired within the ward. This is a true outcome for patients, because if you extrapolate the baseline, the 3-4 months, the 3 first months to the rest of the time, it means for the 6 participating hospitals, it means a reduction of 1,100 patients, fewer patients with pressure ulcers in the wards. So I hope with that to be able to show you one very concrete and practical way that we are using in the hospitals of Western Switzerland to really transform quality and safety in a country that is very lagging behind in terms of quality and safety because of the wrong belief that we have the best healthcare system in the world. Thank you.
네, 프로그램장님 귀한 말씀 잘 들었습니다. Thank you very much. Please return to your seat. 네, 이렇게 환자의 의료질 향상을 위한 스위스의 전략을
Thank you for sharing
소개해
Switzerland's strategy on
이로써
improving
세션
patient
1회
safety.
준비된 두 개의 발표 여러분 만나보셨고요.
This concludes the
여러분,
2
저희는
presentations for
잠시
session
시간을
1.
가진
Let's take a
이후에
short break
전략에
and
대해서
move on
그리고
to
토론 시간을
Asia's
갖도록
presentations.
하겠습니다. 네, 여러분 저희는요.
followed by a
다음
panel
세션
discussion.
오후 3시에 시작이 될
We'll resume the
예정이니까요.
session
시간 잘
at 3, so
즐겨주시고요.
please enjoy your
이곳으로
break
다시 3시까지
and
입장해
return
주시길
to your
부탁드리겠습니다.
seats by 3
Ladies and
p.m.
gentlemen, now we will have a short break and we will resume with the afternoon session, session 2 from 3 p.m. Please enter the hall by 3 p.m. Thank you very much for your kind cooperation. 네, 여러분 잠시 안내 말씀드리겠습니다. 네, 저희 약속한 시간이 5분 뒤에 됩니다. 여러분 장내로 입장해 주시고 착석해 주시고 저희 세션 2 함께 하실 준비를 부탁드리겠습니다. Ladies and gentlemen, please enter the hall and please be seated. We'll soon commence session 2. Please enter the hall. Thank you. 네, 여러분 다시 한번 인사드리겠습니다. 건강보험심사평가원 국제심포지엄 함께하고 계시죠? 지금부터는 세션 2 시작하도록 하겠습니다.
And now let us
오늘
begin the
세션
second
2의 두 개의
session.
발제와 또 마지막
We have
세션인
two
패널 토론까지
presentations
준비가 되어
and
있습니다.
of course
여러분 끝나는 시간까지
the panel
현장에
discussion.
계속해 주시고
Please stay
또
with us
멀리서
until the
온라인으로도
very
시청해
end,
주시길
both
부탁을
online
드리겠습니다.
and offline
앞서
participants.
세션 1에서는 북미와
So in the
유럽의
previous
사례를
session,
보셨죠?
we talked
의료질과
about
환자
cases
안전에 대한
in
권한과 또 발전
Europe
방안에
as well
대해서
as
저희가 심도 있는
South
발표를
America.
들어보는데요. 이번 세션에는 아시아의
And
사례를
in this session, we will
소개드리겠습니다.
talk about
먼저 첫
cases
번째로
within Asia.
유이치 이마나카
First of
교수님을
all, I'd like
만나실
to introduce
텐데요.
Professor Yuichi
교수님께서는
Imanaka.
현재 일본 교토대학교에서
Currently, Professor
대한민국
Yuichi
공중보건대학원
Imanaka
교수로
is a professor at the
재직
School of Medicine and Public
중이시며
Health at Kyoto
사회를 위한
University in
가치
Japan.
창조
Also, he serves as the founding
이사로도
director of the
활동
Value Creating Design Hub for
오늘은
Super Aging
위기 경험을
Societies.
건강과
Today, he
웰빙을
will
talk
talk about
공세,
transforming
스마트
crisis
사회로의
experience
전환이라는
into
주제로
symbiotic
발표를
smart
준비해
society
주셨다고
for
합니다.
health and
네,
well-being.
교수님 무대 위에 함께 해주셨고요. 여러분 큰 박수와 함께
Please give him a
맞이해주십시오.
big round of applause.
My name is Yuichi Imanaka from Japan. First of all, thank you very much for inviting me to this very precious symposium. Thank you very much. Well, today, my presentation have three parts. Part one is pandemic impact on health systems and economics, and need for resilient symbolic society. Well, pandemic is almost over, but we have to review, and based upon our experience, we have to strengthen our health systems. And the second part is to visualize regional disparity in health and health care. Well, regions are very important for crisis management and also for usual daily care. And the third part is to design and realize resilient symbiotic smart society. Well, I am going to introduce our trials, attempts to do this. Okay, this is I'm talking about the part one. Well, this is the changes in hospital revenues at the very early stage of pandemic. The first half year of the pandemic started. And in Japan, for these acute care hospitals, at least we need 1% plus 1% profit rate to sustain hospitals. But in the crisis period of COVID-19, many acute hospitals input a lot of resources to care COVID-19 patients, and they lost a lot of money. Like profit rate was minus 30% or so. We need at least 1%, but minus 20% or 30% is a critical damage. And under this situation, many hospitals will go into bankruptcy. And so the government decided to input a lot of subsidies to healthcare facilities, particularly in hospitals who care COVID-19 patients. Well, to our department, hundreds of hospitals provide us the individual level patient data by monthly claims data. And so we can monitor what's happening in each hospital and also the overall in Japan. And we can feed back this kind of analysis outputs to the government and hospitals and hospital associations. And this is the transition of sales by industry type. After the COVID-19 started, as you can imagine, service industry went down a lot, and manufacturing services also went down, and ICT areas was somewhat better than usual. And this is the data through household consumption survey. And as you can see, travel, particularly overseas travel, went down nearly to zero. And eating out or restaurant services went down a lot. And on the other hand, in-house or at-home alcohol consumption at home increased. And many industries have damage, as in other countries, and the government input a lot of money to help them. And this is the state of the government finance. This is a very long term. The left end is 1975, and the blue line is the income, tax income, and the red ones are the government expenditure. The gap is the debt, and the gap is supplemented by the bar chart. Bar chart is the government debts. And our Japanese government have been accumulating the government debts. And in that year, in the first year of the COVID-19, government used a lot of money, and it was like this. The expenditure doubled, and the government debt was tripled 3 times. And this will influence our healthcare financing. And many people are somewhat afraid. Okay, on the other hand, I'd like to show you some disease-specific impact in healthcare. Well, at the early stage, the government decided to close the schools for a while. And after the closure of the schools, infection went down dramatically. The red line in the graph was the infection diseases. And after this closure, the respiratory infection, this is a children's case, pediatric cases. And this is the number of inpatients. And respiratory infections and GI infections are decreased dramatically. And they are human-to-human transmitted infection. And on the other hand, appendicitis or UTI, urinary tract infection, didn't have an influence. They are not human-to-human transmitted diseases, very clearly shown. And in many diseases, the patients decreased. This is the case of acute coronary syndrome, including acute myocardial infarction. They decreased. And also in the stroke and ischemic stroke, after the COVID-19 and after the declaration of emergency statement, patients decreased a lot. And this also affected the hospital's revenue dramatically. on the other hand, alcohol-related hepatitis and pancreatitis increased. Most of the diseases decreased, but this is one of the rare area which increased. And particularly intensive care units who have COVID-19 patients, who have more stress. Staff have more stress and less time to care patients. And in hospitals which have COVID-19, the physical restraints of dementia patients increased. And in hospitals which did not care COVID-19 patients, the restraint prevalence was almost the same. And this shows the stress on the staff. And this is shown by the age subgroups, and particularly pediatric patients in hospital, and for outpatients, patients decreased a lot. And when we looked into elective surgeries by various disciplines, particularly ophthalmology patients surgery decreased dramatically, like less than 30%. And ENT also decreased a lot, like they went to about half. And after that reduction, that continues and don't recover for a long time. And this triggered the patient's behavior and the patient's decisions regarding healthcare and surgery choice. And this kind of graph, transition graph, is very similar to this diagram. This is the disaster risk management framework by the United Nations. After the disaster, activities went down, and usually they have a recovery slowly. And after modification of this diagram, well, we need more prepared social systems and more resilient communities. We need both social systems and also resilient communities. Then we can have smaller damage, and we can have more speedy recovery, and we can also experience rebound growth. Well, particularly at the early stage of pandemic, we compared the countermeasures and the policies of the government of Japan to Korean systems, Korean measures, and also Taiwan countermeasures. And compared to your country and Taiwan, Japanese policy and countermeasures were very behind, particularly at the early stage of COVID-19. And we have been reviewing how to make the more prepared system, integrating multiple stakeholders. And also we need more effective risk communications and community resilience. And this is also a public health problem. And after that, Japanese government also produces lots of effective countermeasures, and we catched up. But the first start was not very good. For the resilient social system, we need to secure safety net, and we need a culture of preparedness. We need input. We need to put more higher priority in preparedness, and we need a culture of prosperous coexistence, and we need credible, flexible, agile responses through healthcare, government, business, community, co-management. Yeah, we need collaboration, and we also share information, and we need co-management. Each stakeholder should have a positive commitment, positive and productive commitment for as management. And science and technology and data and evidence are very important. And we need good literacy in the side of the government and the politicians, and in the communities also. And I'm moving to the part 2. Well, for health crisis management, region is very important. And also for usual care, the regional system is very important for patients. And so, and also to tackle with the crisis and the risks, region is a very region, and the communities and local governments are very important to make good preparedness. And so we need to visualize regional performance of the regions. And for health for all society, we have to tackle the disparity in health and in healthcare quality. This is just an example of quality indicators at regional levels, not at hospitals, but at regional levels all over Japan. Each bar represents one region. This is the graph which covers 550, around 550 secondary medical areas. In Japan, we have 47 prefectures, and each prefecture set several secondary medical areas. And in Japan, as a total, we have about 350 secondary medical areas. We measure quality indicator for, not for hospital, besides hospitals, for all regions, each regions of all the secondary medical areas. And these are examples. The left half is myocardial infarction, and the right half are ischemic stroke indicators. And on the other hand, we can also measure quality of long-term care. We have a public system to ensure long-term care, and we can measure the quality of long-term care in each municipality. And for example, the one of performance indicator is risk-adjusted worsening rate of quality of life. And this is very important indicator. And this differs. Usually, in healthcare, in urban areas, we have much resources, and the performance is good compared to rural areas. But in terms of long-term care, some rural areas have very good performance and very good coexistent society. And in Japan, regional comprehensive care system is a policy target. We'd like to improve that system for the well-being of particularly elderly people. And the regional comprehensive care system covers health care and long-term care, and also living arrangement, and some social activities. And we made up data charts for each municipality to understand what's happening in each municipality. And on the other hand, we need outcome indicator to assess the situation of each region. And using the long-term care claims plus alpha data, they have very detailed information on the activity levels of an elderly older person, and we can measure dementia-free life expectancy in each municipality and each secondary medical area. And we found some variations among regions. And I will show you this one. As you know, now the source determinants of health is not only by health care. Health is determined by health care, but also the other social factors are very important, including individual lifestyle factors and the social and community networks, and also various functions of the society and the infrastructure of the society. And this is another kind of graph to support the well-being. Healthcare and social care is very important, but social economics activities and infrastructure of the society is the basics to produce well-being and health of the people. And we measured, to understand the mechanisms, how important each factor is. To do this, we have to measure the well-being or the health of the people numerically. And so one example is this, and we can also measure life expectancy also. And on the other hand, social economic indicators are very important, and so we calculate social economic compact indicators, which represent the vulnerability of the people in each region. And this is one of the output of the analysis. Socio-economic determinants of healthy longevity are very important. And for example, the variation of healthy longevity of female people were 20% of the variation was explained in female. And in male, 50% were explained by the social economic determinants. And also, this is another kind of representation which deals with life expectancy. And when we look into various social economic factors, we found three major factors. One is urbanicity, another is health-related resources, and the third one is socio-economic factors. And in this analysis, socio-economic factor was most explained, most influential to health longevity, for health longevity. But it is somewhat difficult to change social economic factors, and healthcare is more tangible and more effective, and so health and healthcare is very important. But on the other hand, socio-economic factors are also very important. In the third part in my presentation, we are trying to design and realize resilient, symbiotic, smart societies, and I'm going to introduce some trials of ours. To create healthy societies, well, we need commitment of a lot of stakeholders, and we need collaboration among government, industry, academia, community liaison with health and healthcare. And in our university, many professors are interested in how to design society for well-being, for better well-being. And all the professors in various fields get together to make a unit, interdisciplinary unit, to study how to design for social aging societies, super aging societies. And the disciplines include informatics, data science, community organization, and city planning, healthcare, and economics and finance, and law, and that includes conflict management and social psychology. And also industry, government, academia, fusion department also joined. And based upon this interdisciplinary unit, we collaborate with various industries, and we made a policy proposal. The leader was Kyoto University of ours, and we made a policy proposal for healthy smart cities by Council on Competitive Nippon, Japan Council on Competitiveness. This includes many companies in the below of the slide joined. Many influential big companies joined for this proposal. And alongside, we also created the Industry, Government, Academia, Citizen Consortium for Social Design of People's Well-being. This is called Pegasus. And we made up the model for health framework for smart health city. And this includes 11 domains, including housing, transportation, and education, and social inclusion, social participation, and workability, and including also healthcare. And we are now trying to measure the performance of each of these 12 domains. And we are trying to grasp comprehensively the region, and we are trying to utilize this kind of data for the analysis and also for the design societies for welfare. And this is image cartoon of these 12 areas, and this covers all the 17 SDG goals. And And to realize resilient societies, we need to visualize the vision. So we need to common understanding what we are aiming at. And so, including multidisciplinary researchers and practitioners, we created this book to show the concrete image with examples what we are going to aiming at for resilient symbiotic society. And this is a key point for future. We need to strengthen the resilience of our societies, communities. Healthcare is very important in this. And the second, we have to reconstruct flexible cross-border collaborative social systems. And the third, we need to develop scientific technologies to grasp total system of societies, including health, economics, behavior, and policies. And what we need is comprehensive approach to health and well-being through a restructuring society towards resilient symbiotic societies. Thank you very much for your attention.
Thank you. Thank you for your presentation. 유이치 이만아카 교수님께서 발표를 전해주셨습니다.
Thank you very much,
공생,
Professor.
스마트 사회를 실현하기 위한
talked about how to
형평성 있고
realize
또 회복력 있는 보건 의료
smart
시스템에 대해서
welfare
소개해 주셨습니다.
societies
뜻깊은
and
말씀
create
잘
equity.
들었습니다.
Equity.
자,
Thank
이제
you very
세션
much.
2의 마지막 발표를 소개드리겠습니다. 마지막 발표는
We're already at the final
권영우
presentation.
건강보험심사평가원
Continuing, we have Mr.
진료
Kwon Young-wook,
심사평가위원회
HIRA
위원님께서
Healthcare Review and
준비해
Assessment
주셨는데요.
Committee member.
위원님께서는 현재
Mr. Kwon is currently a full-time member of the HIRA
건강보험심사평가위원회
Healthcare Review and Assessment Committee.
상임심사위원으로 재직 중이십니다. 오늘은 미래 보건
Today he will be
의료
presenting
시스템을
on the
위한
topic the role of
적정성
adequacy,
평가의
quality
역할이라는 주제로
assessment for the
귀한
future
발표를
healthcare
준비해 주셨다고
system.
합니다. 네, 이제 준비가 되신 것 같은데요. 여러분,
I
큰
believe it's
박수로
ready.
환영해 주시죠.
Give him a big round of applause.
네, 반갑습니다. 네,
Hello,
신병원에서
everyone.
근무하고 있는 권용욱이라고
My name
합니다.
is Kwon Young-wook and
제가
I work at
이
HIRA.
미래의 보건 의료 시스템에서 적정성 평가의 역할이라는 주제를 처음 부탁을
When
받았을 때
I was asked to present on the role of QA for the future healthcare system, I wasn't sure if I had enough expertise and experience to present on this topic. In Korea, when you say a healthcare professional, we usually refer to experts in clinic trials or medicine. Unlike them, I work in assessment and review, and also my expertise lies in supervision. So I was wondering if I would be the right person for this topic. I'm sure that medical professors have a different perspective on this topic and can comment on more details, but I will approach this from a bigger picture perspective, from a systemic perspective. So let me actually share my thoughts on this very topic.
현재 보건 의료질을 어떻게 향상시켰는지에 대해서 간략히
I will briefly talk about how our QA improved healthcare quality and what the future role should be for QA moving forward.
그 역할을 하기 위해서 우리 적정성 평가가 어떻게 변화해야
And in doing so, how should we take this further in developing and applying an integrated assessment framework?
적정성 평가를 하는 우리 심평원은 말 그대로 심사평가원,
HIRA,
심사와 평가를 하는 회사입니다.
as the name says, is in charge of review and assessment.
심사는 할 수 있는가에 대한 질문이고,
Review is about whether you're doing your job, and assessment is about whether you're doing your job right.
MRI를 어디까지 찍을 것인지.
Review, for example, looks at whether, to what extent you want to take MRI scans. Did you take more MRI scans than needed? That is the question that you need to answer in terms of review. But when it comes to assessment, when we have a stroke patient, this is the minimum requirement. The minimum requirement is to take at least one MRI scan whenever there is a stroke patient. situation, regardless of their social status or income, regardless of which hospital they go to, which region. The minimum requirement for a specific condition or situation would be the assessment factor. HIRA first started out as a review company, and when we first rolled out the universal health coverage back in 1980s, the whole idea was to make sure that nobody is left out outside of the universal health coverage. If we had unlimited resources, it would be great, but under limited resources, it is important to apply standards and make sure that medical professors carry out practices based on the guidelines that we provide. But as time progressed, we realized it's important for the patient to see the doctor, but what's more important is for the patient to see a good doctor and also find a good hospital. That's why and how we brought in the whole assessment factor into the picture. That's why review and assessment, both of them, are equally important responsibilities of ours. The provider is a very important part of the assessment. Our goal is to make sure that the public has access to good quality providers. So provider will be one important aspect of our assessment. And in order to identify which providers are good quality providers, we share the assessment results with the public. When we say assessment, we are not the only one who's in charge of the assessment process. Assessment is only a small portion when it comes to policy making. The actor who's in charge of making policies and making appropriate choices would be the government. The government takes these assessment results and apply to their policy-making process when it comes to healthcare. And that's why the government is involved here as a part of the QA process. The QA process began in early 2000s. It started with drugs. Drugs were a big topic back then. So back then, the whole healthcare system, the division between prescription and medication was very clear, and there was a lot of social debate going on about that. That's why we began with drugs for assessment. So we began with 5 items for assessment, including covered drugs. And when the system was more or less stabilized, we added more items such as diabetes and hypertension. So we added some clinical area items. And we also first started out with first care and also second care, but later we rolled it out to specialized hospitals as well. And the whole focus was not on doctors, but on patients. We started doing patient-centered satisfaction assessment, and right now we are doing about 37 items as part of the QA. There were challenges along the way, obviously. Some people asked, shouldn't we be more proactive about assessment? I think our system is currently too focused on providers. And from medical professional and provider perspective, they would say you're too focused on technical concerns without having knowledge about what's going on in the front line. But despite these challenges, the reason why we were able to carry on was because we had good results in many aspects.
질환에서는 항생제를 사용하지 않다는 것을 너무나 잘 알고 있습니다. 하지만 항생제를 많이 사용했죠.
It is very obvious now that we don't use antibiotics for the common cold, but before assessment began, it was very common to prescribe antibiotics for the common cold. But with the whole assessment program introduced, we were able to reduce the prescription rate for antibiotics for the common cold. And also, we was able to provide more strict guidelines when it comes to preventive antibiotics for surgery processes. And when it comes to strokes, we were able to reduce the rate of death with the introduction of assessment. And when it comes to QA performance, you can see that in terms of NCD in patients for hypertension, diabetes, asthma, and COPD, we continue to implement QA and made sure that the rate for NCD inpatient reduced over time. QA has definitely contributed to improving the quality of care in Korea. But the real question is, what is the future role of QA going forward? I'm sure that everyone here is very concerned about the future because no one knows what's going to happen. If imagine that the future will be totally out of control, then that means that we have to change the current system. But let's actually not think about the future for now. Let's think about the present and past and even before the past. For example, yesterday is the past from today's perspective, but yesterday was the future from the day before's perspective. I'm sure that in the past we also had concerns about the future, but looking back, we did a good job of responding to changes along the way. So looking back at the past and the time before then, you'd probably realize that there aren't a lot of differences that we are talking about. Then looking at the future, we don't know what's going to happen, but changes will happen within our control, and what we have implemented so far will probably work. It looks like we have come a long way when compared to the past, but the changes have actually been incremental, so it will not be anything drastic or anything too out of control going forward as well. So we believe that QA will continue to have relevance in the future, but it can still be a little bit different than what it is now. We will probably have more areas of assessment, so we'll have more assessment targets. If you want to assess something, then it has to be something that's already pretty widespread. If you have a disease that no one can cure, then you can't really assess it. It has to be common and widespread enough for us to be able to assess it. In the past, that was pretty limited to hypertension or diabetes, and cancer was out of our assessment range because cancer was considered as something that's not curable. But right now, we assess cancer because cancer is something that we can now cure. So going forward, similarly, just like how we tackled cancer, there will be diseases that are newly added to our assessment package. And right now, a lot of the bulk of assessment lies in medical field. Like we focus a lot on medical professionals. But like I said before, patient experience is important as it's already part of our assessment process. patient rights and patient experience continue to be hot topics. And not only doctors and patients, but other stakeholders should also be considered as part of the process. So we will have more stakeholders in the picture. And there will also be IT-related changes. So I actually specialize in neurology, so these days, in the past, we use a lot of basic tools to assess a lot of things. For example, you would actually hit your knee to see if anything is wrong with your brain or if your neurons are responding. But with the development of ICT, we no longer use those very basic tools. We can just simply take MRI scans, and even when it comes to rehabilitation, you can use technology. So ICT will increasingly play a role in the medical field, and IT developments will become faster than we expect. That's why we also need to think about how to integrate IT in our assessment programs. In that regard, I think that we need to come up with an integrated assessment framework. When we say integration, that means we're adding different areas. 1 + 1 = 2 mathematically. So that's where the mathematical concept of addition comes in. But I think simple mathematical addition shouldn't work when it comes to effective integrated management. So going forward, we should be able to utilize both additions and subtractions. Sometimes subtracting leads to better results. Just like how we see chemical integrations in our daily lives, it's important that we consider the concept when it comes to integration. One thing that I want to emphasize here is that I want to explain what's important when it comes to integration. If we do a good job of adding things and subtracting things, we should be able to develop a very balanced integrated framework that will be able to respond to future challenges. So let's look at addition. Addition is something that we do really well. So whenever there's a new challenge or a new item, then we add items. So remember we started out with drugs as part of our assessment process, and then we added different diseases. And we also added some mental health related items. And lastly, we added patient safety items. So whenever there is a new challenge or policy items on the table, we add them to the system. But like I said, if resources were unlimited, then we don't need to worry about adding more items. But because resources are limited, we will reach a limit at one point. And that's why we need to balance it out at some point. The whole point of assessment is to make sure that we contribute to raising care quality, but if assessment comes in the way of providing quality care, then it is against the original objective. So when it comes to subtractions, subtraction is necessary to really stabilize and balance out the whole system. We are already doing this. Assessment items increase from 5 to 37 items, but whenever we achieved a certain objective, and whenever we decided that what we are doing is not in alignment with policy objectives, we subtracted items too.
굉장히 긍정적인 효과가 나타날 수도 있지만 사실
As we added more items, that means we need more professionals to assess, and that could be a good thing, but at the same time,
많은 정책적인 부분을 이해를 해야지 가능한 겁니다. 하기 때문에
because assessment requires understanding of policy-making process as well, in addition to the medical knowledge,
위원회 등도 지금 저희가 통합 작업을 하고 있고요.
we are actually in the process of putting together a committee to run the whole assessment program.
항목안에서의 지표, 그러니까 시험 문제들
And even if we were to maintain certain items, we mix up and change assessment questions and criteria.
그 문제가 굉장히 중요하다고 인식했기 때문에 만들었기 때문에 이 시험 문제를 바꾸게 되게 되면
But changing up
중요성
test questions, assessment questions is difficult because
여러 가지 문제가 있기 때문에
changing existing questions might,
굉장히
give an impression that those questions are not important anymore.
시스템을 안정화시키기 위해서 2022년 작년부터
So in order to stabilize the assessment system,
16개에 대해서 지표 정비 사업을 해서
we
그런 효과를 얻었습니다.
actually did some overhauling for 16 areas.
6.4를 정도로 우리가 정비를 했고 뭐 중환자실 같은 경우는 64.3%라는
So we actually
우리가 이런 정비가 가능했던 거는
did an overhauling of about 65% of the assessment items and indicators.
전문가들이 그런 소통을 통해서 우리가 이루어낸 거라고 생각이 듭니다.
I think this was a good result that was achieved through communication with medical professionals and also assessment reviewers.
사람의 이주입니다. 사실 의료기관이나 환자 같은 경우는
But when it comes to assessment, adding items or subtracting items, that's the whole concern of providers and also assessment reviewers. When it comes to the public, the patients don't really care how many items are out there to be assessed. Whether it leads to good results that's beneficial for me, that's the real question they would be asking. That's why
의료기관, 정부가
the public providers and government all need to agree on the fact that assessment is needed. They should look forward to assessment results because it would serve all of their benefits.
필요성을 중심으로 똘똘 묻혀야 됩니다.
That's why it's important to align all three
이 주체들이 평가를
actors in the system. We need to raise awareness of the importance of QA. And in order to do that, we need to be able to persuade all three actors that QA is beneficial for them.
국민을 위한 평가를 하기 위해서 먼저
So-
결과 지표를 중요하게 생각하는데
We put a lot of emphasis on result indicators because we want to provide public-centered assessment. When doing assessment,
내가 그 병원을 갔을 때
whether a provider is doing good practices is important, but from patient's perspective, whether I feel safe or whether there will be any side effects is actually more important from experience standpoint. That's why we added mortality rate as part of our assessment item so that patients can feel safe
낼수 있을까에 대해서
about
그런 평가를
whether
하고
they
있고요.
can draw good results by visiting a specific
우리가
healthcare provider.
이제 전화로만 하고 있다가 지금 현재는 문자를 보내서
And also,
외부로 평가를 받을 수 있게 돼서 아무래도 전화를 받을
we are
때
utilizing IT by
바로바로 이렇게 대답을 해야 되니까 제대로
asking for
환자가 좀
post
불편할
survey
수가 있지 않습니까?
through
근데 이제 외부로
text.
하면 보다
Previously,
조금 더
we relied on
생각하고
phone
할수 있기 때문에
surveys, but then we realized that this can be a little bit of a burden, like a psychological burden from patient standpoint. So we are actually
우리 심평원은
getting out
그래도
survey links through text
많은
messages.
분들이 알고 또 적정성 평가를 활용을 하고 있지만 대부분의 공공기관에서 수십억을 맞는다 하더라도
Although HIRA
그
is
정보가
very
있는
famous for
홈페이지에
its
접속하는
assessment program,
일반적인 사람들은 굉장히 적습니다. 그래서 홍보가 굉장히 중요합니다.
it's very important to also drive traffic to our official website.
최근에 굉장히 마스코트도 이렇게 예쁘게 만들어서 굉장히 공격적인
While our assessment results are already being utilized proactively, we came up with very public-friendly characters, as you can see here, called Hito and Todangi, to become more public-friendly, to drive more traffic to our website. And we have been doing a lot of activities in terms of promotions, like creating promotional videos. And then we've seen an actual increase in traffic and also awareness in what we do. This is part of our promotional video.
평가를 받는 의료기관도 평가를 원해야 됩니다. 그러기 위해서
Providers should also seek out for assessment. That would make the whole process so much easier.
조사표라고 해서
Up until this point,
일일이 다 적어서 입력하는 형식입니다.
the whole system has been manual.
굉장히 피로도가 높고
We visit the healthcare provider and then we copy everything in handwriting. So the whole process was very taxing for both us and the provider.
자료를 받는 부분이 있습니다. 그래서 많은 부분을
So we actually started to computerize, digitize
하게 되게 되면
the bulk of the process by
불편함이
copying claims data from providers to create like an electronic system.
환자가 많이 오니까 경영상의 이득을 보겠지만
With good assessment results,
자체에
more
대해서
people will visit
잘 받았을
the providers,
때문에
so it will be good in terms of revenue. But other than that, we also came up with this incentive program where we pay for their performance.
할 수 있을 겁니다.
So we provide subsidies to those providers that with better results.
결과를 활용할 수 있게 만든다면
Also, we thought it's important that the government thinks our assessment is valuable.
과거에는 심사가 어떤
In the past,
정제성과 그리고 과학적 그런 지식을 토대로 이제 했다고 한다면
assessment was based on economic value and also scientific methods. But going forward, it's important to actually look at whether patients are getting valuable services and patients are getting better through the services that they get. So that's another aspect of QA that we're doing.
우리 적정성 평가를 이용하는 하나의 사례가 될 거고요.
So that will be one very useful case
이슈들
of assessment
환자들이 너무나
for the government.
수면제 같은 거를 먹거나 좀 진정되는 약을 먹어서
And also,
많다 뭐 그런 게 있으면
let's say that the elderly is reportedly consuming a lot of psychotropic drugs and there are a lot of falling accidents because of that, then we get the data and then we actually talk to the providers to see improvement in terms of psychotropic prescription. So that's another use case, for instance, that assessment results can be used.
결국은 플러스든 마이너스든
Be it addition or subtraction,
결합. 그러니까 평가에 참여하는
what I want to really emphasize is integration.
이 평가가 정말
All
필요하다고
actors that participate in the assessment process should feel that assessment has value. And with that, I'm sure that QA will have an important role to play in the future. Having said that, I'm sure that we will continue to have tasks to resolve. We will have challenges related to IT about consideration for information consumers.
환자들이 평가를 하게 되게 되면 사실
And
그런 분들은 사회적 약자에 해당.
also, as we adopt more IT into our system, are we leaving out those vulnerable groups in our society, like the elderly or those who do not have access to IT? Those are some of the questions that we need to ask as well.
평가의 편의성을 위해서 심사 청구 자료를 사용하고 있지만
We have started to use claims data to computerize the whole process I mentioned earlier. But claims data cannot replace our materials for QA. So we need to come up with a different way of importing materials for QA. Also, when it comes to incentives, we are trying to provide incentives, but does that really work as an incentive for providers? That's the question that we should ask ourselves. And lastly, those who
임상가들이
develop assessment questions? Are they aware of what's actually happening in the field? Do they have enough knowledge and experience and understand the perspectives of medical professionals for actually practicing?
라고 생각이 듭니다.
We need to make sure that our assessment is not out of touch.
우리가 평가라고 하는 거는 기술적인 부분에 대해서 지금까지
Assessment has been heavily focused on technical aspects until now.
적정성 평가는 굉장히 효과적으로 생각이 듭니다.
QA in the future will still play an effective role, but the moment that our actors, our participants, think that assessment is not needed, it's over.
이 주체들이
It doesn't matter whether outsiders or the rest of the world thinks that our assessment is valuable or effective. It is important that the actual participants, the 3 participants, see value in our QA programs.
스스로 하고 싶어하고 필요하게
They should want to be part of the assessment process.
이들의 마음을 헤아리고
In order to do so, we need to keep
평가를
going back to what
합쳐지게끔
drive
적극적으로
them.
노력을 기울여야 됩니다. 그렇다고 한다면 미래에 어떤 변화가 있더라도 우리는
And with that, no matter what changes come our way, we'll be able to navigate them. Thank you very much.
부탁드리겠습니다. 열정적으로 발표해 주신
Thank you so much, Mr. Kwon, for your passionate speech.
이로써 저희가 준비한 세션
That concludes the second session of the afternoon.
저희는 지금부터 약 10분간 휴식을 취하도록
Let's take a
하겠습니다.
10-minute
잠시 후
break
토론 준비와 함께
before we
여러분과
actually
세션에서
dive into the
다시
panel
인사드리겠습니다.
discussion.
그럼 잠시 후 뵙겠습니다.
Thank you very
고맙습니다.
much.
네, 여러분 잠시 안내 말씀드리겠습니다. 저희 잠시 후 4시 10분에 마지막 순서인 패널 토론 시작하겠습니다. 아직 장내로 입장하지 않으신 분들은 입장을 서둘러 해주시고 착석해 주시길 부탁드리겠습니다. Ladies and gentlemen, we'll soon commence panel discussion, which is the last session of today's event. May I ask all of you, please be seated. Please enter the hall. Thank you. 네, 아울러 패널 토론에 함께 해주실 연자분들 그리고 패널리스트 분들을 저희가 무대 위로 모시겠습니다. 착석해 주시면 고맙겠습니다. We'd like to invite our esteemed panelists. Please come up to the stage. Once again, we'd like to invite our distinguished panelists. Please come up to the stage and please take your seats onto the stage. 네, 여러분 다시 한번 착석을 부탁드리겠습니다. 아직 장내로 입장하지 않으신 분들께서는 입장을 서둘러 해주시면 고맙겠습니다. Ladies and gentlemen, we'll soon resume with the panel discussion. Please make your way inside the venue and please take your seats. Thank you very much for your kind cooperation. 네, 끝까지 현장에 배석해 주신
Thank you
모든
very
참석자
much
여러분께 진심으로
for
감사의
staying with us
말씀을
until the
드리겠습니다.
very
여러분, 이제
end.
저희가
We started in very early hours of the morning, and now we have the very last order of events. I'm talking about the panel discussion. Let's have an in-depth discussion. Today we have Professor Yoon Seok-jun from Korea University who will be presiding over today's panel discussion. Let me introduce each and every one of them. Please greet them with a big round of applause. First, we have the professor from Korea University, Professor Yoon Seok-jun. Thank you very much. Next, we have Mr. Carsten Engel, the CEO of ISQua. Please welcome him.
CEO of ISQua. Thank you.
And next, we have our speakers of today's symposium, Mr. Jeffrey Braithwaite, the president of ISQua.
Thank you for your attendance.
Also, we have Ms. Salma Jaouni, the CEO of Healthcare Accreditation Council of Jordan. So we have our two keynote speakers here with us on stage. And next, we have Mr. Joel Roos, the Vice President of JCI. Thank you very much. And next, we have Mr. Anthony Stanis, the Director of Hospital Federation of VOUD. And next we have the speakers of our second session. First of all, from Kyoto University, we have Professor Yuichi Imanaka. And next, last but not least, our last speaker, we have Mr. Kwon Yong-wook, HIRA's Healthcare Review and Assessment Committee member. Please give him a big round of applause. And now I'd like to ask Professor Yoon to take the floor.
You may now have the floor.
So should I speak in English? Okay, I think that would be better for all of you.
Good afternoon, everyone. Before we start our panel discussion, please set your phone to silent or vibrate mode. My name is Seok-jun Yoon, and I'm a professor in the Department of Preventive Medicine and Dean of Graduate School of Public Health of Korea University. And I will be serving as your moderator today. It's a great honor for me to be the moderator for HIRA's International Symposium 2023. Today's symposium focuses on preparing the future healthcare system by strengthening the integrated healthcare system. On this subject, 6 speakers have described for us examples from Western and Asian countries. In his keynote speech, Dr. Braithwaite, the president of International Society for Quality in Healthcare, noted the 60-30-10 challenge and the complexity, non-linearity of medical services while offering some solution to this problem. And Ms. Jaouni, Chief Executive Officer of Healthcare Accreditation Council of Jordan, highlighted the importance of primary health care for universal health coverage and the role of HAC-AC accreditation. After that, in the first session, Dr. Roos, the Vice President of JCI in America, emphasized the importance of remote technology and argued that healthcare services will shift from hospital to patient home. Therefore, ensuring medical quality and patient safety is a key challenge. Dr. Shin, program leader of the Federation of Board Hospital, gave us an example of improved hand hygiene in Switzerland through systemic change, education, evaluation, and feedback. In the second session, which focused on Asian cases, Professor Yuichi highlighted the negative impact of the COVID-19 pandemic on healthcare system and the need to address regional imbalance and strengthen the collaboration among government, industry, academia, and local communities. Lastly, Dr. Kwon showed the history of challenge on healthcare assessment of HIRA. To start our panel discussion today, let me introduce Dr. Engel, the Chief Executive Officer of the International Society for Quality in Healthcare. Dr. Engel, would you like to begin by giving us your thought about any of the previous speakers' presentation based on your experience?
Thank you, Professor Jung. We have heard some very interesting and thought-provoking presentations today. What I would take home from having heard it is a number of things. First, we heard that healthcare is an extremely complex system. We need to understand that, but we also need to embrace it, because complexity is what gives healthcare the ability to be a learning system, a system that can change itself from inside, which a complicated, designed system could not do. It would only be able to produce what it is supposed to produce. So we must understand and embrace complexity. We must think in terms of systems. Patients are not wanting good healthcare provider organizations. They want a good healthcare system that can care for all of the needs. And when the hospital becomes a hospital without walls, as Joe Rose told us, I think that will facilitate the transition towards a person-centered system, because when we are caring for a patient in his or her own home, then very naturally this person becomes the center. And we must teach ourselves to view quality not from the systems perspective, not from the provider perspective. Am I doing my right properly? Of course I need to do it, but at the end of the day, it's what the patient receives that matters, and we all know that a sum of 5 good services need not necessarily become a total good service. So the patient and person-centeredness is an important thing to take home. We heard that it's important to know the quality of the systems. Anthony Stein told us it's not as easy as you might believe, and you can't assume that high costs equal high quality. But we have also seen a number of different ways in which we can become wiser about our quality. Salma Jaouni talked to us about accreditation, and that was implicit in Joe Rose's talk, of course, as well. And accreditation is one way of doing it. Mr. Gon explained to us the extensive system of quality indicators used by HIRA. That's another way of doing it, and I think we know we need both ways. They are complementary to each other. One gives us hard data on what is going on, whereas the examination we can do by examining our processes by the accreditation survey methodology can enhance our insight in what we have been doing. And I think when it comes to understanding quality, we have a bright future ahead of us. We heard a couple of days ago in the ISQua conference a keynote presentation on artificial intelligence, and one of the things that was demonstrated to us there was a system where the AI scans a large number of MR or CT scannings and flags the ones in which there are subtle signs that indicate this you should look at. This may be a hemorrhage. I assume that we will soon find ways in which we can let AIs do the same thing to quality data, so that we don't need manually to review all the data we collect, but can have a system that flags where the problems are and helps us use the data we have in a much better way. And thinking systems, it's also important that we use data not only from healthcare system. We heard that healthcare only accounts for 10% of health outcomes. So shouldn't we integrate data from the other 90% as well, if we want to understand really what determines the healthcare outcome one particular patient experiences?
Thank you. Thank you for your nice discussion. Dr. Braithwaite, right? Braithwaite. Yeah, let's move to the Dr. Braithwaite. Please add on your thought or idea and experience.
Professor Yoon, that was may I say that was an excellent summary of a lot of words that were spoken and a lot of slides. Perhaps I could add a few points. So if modern health systems, such as Korea's, have the characteristic that they are complex systems, extremely complex, and they deliver these three numbers, 60% of care is in line with level 1 evidence or consensus-based guidelines. 30% is waste. Now, maybe Korea is a more efficient system than other health systems, but still there will be a proportion of care that is waste. Test results, for example, that don't get seen, or bureaucratic costs that don't deliver value to patients. And 10% harm, and there are some estimates that harm adverse events occur more than 10%, but let's assume those numbers more or less are present in most health systems, and maybe Korea has a better health system and the numbers are better. Well, what about that? What can we do to improve that in a complex system? We've heard many suggestions here, and one way to bring those all together is to say, have we got a learning system that continuously improves? Have we really got that? Have we got a learning health system that is able to exploit all the data that we heard from the other speakers, that is able to put together and give to people the right information at the right time, when they need it, high quality data for patients and for clinicians to make really good decisions? You, Professor, you know, world famous as a policy expert. So how also can we produce the right policies and incentives to encourage people on the front lines of care, where the care gets delivered, to use good data in a timely way to make the right sort of decisions for patients? The other thing I would add is we've been for 4 days at pre-conference workshops and across the ISQua conference talking about co-production. Can we create that learning health system more and more and continuously improve it across time so that the patient's perspective, the patient's preferences, the patient's voice, and the clinician's expertise come together to co-produce the best care possible for that particular patient, delivered by that particular clinical team? I think that's the sort of ideal that we've all in a way been talking about, whether we've given a talk based on concepts or accreditation or standards or data or studies. They would be my reflections, Professor Moderator.
Thank you. Thanks so much. I think Dr. Braithwaite was a former job was an actor, I think. Wow. Yeah, very nice. Yeah, thank you. Thanks so much. Let's move to the Miss Jaouni from Jordan, not Jordan, from Jordan.
Thank you. From the different panels that we've heard or presentations that we heard a lot about indicators. We heard a lot about accreditation as a process or measurement of indicators or measurement of compliance. But all of that is in relation to a set of standards. So standards make a very consistent platform that you can follow to know where you are going, and helps you analyze where you are and where you want to go. And this is very, very important. Many countries, like mine, are challenged by many vertical ideas. So a donor or a government person comes in with a great idea, let's work on this. And they come up with a new way of doing it that they've heard it in a conference like ISQua, for example. But the problem is becomes two things: burden. So we are burdening the healthcare providers or institutions with many interventions that sometimes may be conflicting and other times complementary, and many times just a repetition. And we are doing it for a short period of time. Really, intervention in complex systems needs a long period of time. There are quick wins that you can benefit from, but long period, the data we saw from our colleague from HIRA, where over time, the impact was not done in 1 year, it was over a number of years. So whether it is accreditation or measurement or assessment or even regulation, pick a way to move forward and be consistent with it and give it enough time. And another problem that we face is that our friends and colleagues who do policy and are in government, they sometimes want us to come up with the perfect strategy and the perfect plan. There is no perfect strategy or perfect plan just by sitting behind the desk and trying to design it. We have to bring all the experiences and start implementing. And quality is about continuous quality improvement. So while we come up with our plan, we start implementing and we fix things as we go. It is very important to start somewhere and to move forward rather than wait for the perfect plan to be found out. Last but not least is buy-in from the leadership and understanding, and we saw that in Switzerland, how they want the hospitals to buy into the activity or exercise that they are doing, commitment, repetition, and continuous quality improvement.
Thank you. Thanks so much. Miss Jaouni, 제가 요르단이 아니라 조르단이라고 조금 전에 얘기했던 게 영어로 얘기할 때 요르단이라고 잘 못 알아들으세요.
Said Jordan, not Jordan, because in English it's pronounced as Jordan.
I talk about the difference between Jordan and Yordan to the audience. Yep. Let's move to the next speaker, next discussant, Dr. Ruth. Interestingly, Dr. Ruth, Japan for Major League Baseball team San Diego Padres. Before we participate in this discussion, during the break time, we talked about that the best player of Kim Ha-sung, the best baseball player of San Diego Padres. So I from now on I like to I started to like Dr. Ruth. Yep. Please add on your thought.
So before I start, you are welcome to come visit in San Diego, and we will go to a Padres game together. So. And that's an interesting segue, because if I was to sum today's discussion up, I would do it with one word. And it applies to baseball too. And it's data. All of our talks, in some form or the other, had an underlying theme of data. And we are not going to improve quality, improve safety, improve outcomes without data. But because this talk is also future-oriented, I would also highlight what we didn't talk about. And right now, all of our data we're collecting in tremendous methodologies and yielding results with it, but it's a look back. Going to the future, the combination of cloud computing, huge data repositories, artificial intelligence combined with natural language processing, and from my perspective, I'm now really looking at quality and patient safety, is can we also move forward, and that's the challenge, and become predictive? Can we predict where our safety events are going to occur? Can we predict the next fall, the next accident, the next medication error, and thereby prevent them. And I will highlight a very simple concept. It's a very simple example, but we now have the ability to collect different types of data. And we're right now focused for the most part on outcomes, things we can measure, blood pressures or the like. But what if we start combining what I call disparate sources of data? And I will use the idea of patient falls in a hospital. And let's look at falls, where they occur, nursing schedules, staff schedules, and put that all together and start analyzing it. And suddenly you can say, Thursday evenings on the 7th floor West Wing is 5 times more likely to have a fall than any other time in any other location. Obviously, as that kind of suggestion, now you can implement strategies to prevent the falls, i.e., don't overstaff, look at your schedules. There's obviously different ways you can do that. But that's the next step of where we're going, and maybe next year we will talk about something along those lines, but really none of this will happen without data. And so we have to get comfortable collecting it. We need to develop systems to do it, and we're all talking about it. And I think the future is going to be really exciting as we get more and more data in different formats.
Thank you. Thanks so much. Let's go to the Dr. Staines. I understood interestingly, Dr. Stein is just only unique provider among the participants, right? Yeah. Okay. Yeah. Please add your experience and thought, please.
Thank you very much. I was interested in the diversity of presentations today and to see that there is a diversity of regions, of languages, of contexts, etc. But there are commonalities in what worries us and where we need to go for the future. There are differences in how we do things, but in what we need to do, there are not that many differences, I think. And that reminds me that perhaps we should also add to the discussion one important topic. I was the CEO of hospitals for about 10 years, and then I went back to studies, did a PhD, and my PhD was, the research question was, do quality improvement programs in hospitals lead to improved outcomes for patients? It was very humbling because it's not that easy. It takes time, it takes a lot of things. And one thing that I discovered in this doctoral dissertation was that in quality improvement, it's important what you do, but there is something that is as important and less talked about, and perhaps more important, it's how you do it. So, of course, it's important to select the right methods about doing things, be it accreditation, be it PDSAs, be it breakthrough collaboratives. So it's important to choose a good method. But the how you do it is even more important. So if you do it with the support of top management, it's very different than if you do it without the support. If you have medical buy-in, it's very different than if you don't. If you have decent resources that are in proportion to the goals that you have set for your organization, it's much easier to do. If you have the right data information systems, it will help a lot. So there are prerequisites, there are framework conditions that need to be aligned. I think accreditation, breakthrough collaborative, PDSAs are like seeds that you put into the ground and that will grow. But for them to grow, you need the ground to be fertile, you need the sun, you need to water these plants, etc. And these are the framework conditions, the culture, and so all of these things need a lot of attention as well. Thank you.
Thanks so much. Maybe Dr. Staines gave us very special and unique experience because among these panelists, Dr. Staines is just only unique provider. So Dr. Unique gave us insightful experience. Thanks so much. Let's go to the Asian countries. Professor Yuichi, please add on your thought or experience, please.
Okay. Well, I talked about somewhat crisis management, and maybe due to global warming or global boiling, now natural disasters are getting more and more frequent in my countries too. And hurricane attacked Florida these days, and also mountain fires in many countries, including Hawaii. Well, in the timing of the crisis, disaster management is very important, and we have to do many things quickly, and we have to make liaisons quickly. And also, after that, we have a relatively long-term effects or mid-term health effects. And now, in Japan, we are putting higher priority in BCP of hospitals, business continuity plan of hospitals. Well, in Japan, government designated disaster hospitals, and they already made BCPs. And but now, there is a trend that all hospitals have to make BCPs. But in the accreditation system, we didn't evaluate the BCPs yet. And but in the long-term care facilities, have to have BCPs from the next year. And now BCPs are getting more important, and to realize BCP in the actual world, we also need region-based BCPs, because we need to help each other in the case of crisis. And at the time of crisis, management is getting very, very important, and including manpower, logistics, and how to recruit and organize volunteers, and how to cooperate with the government and public health centers in case of Japan. And if we have time, I'd like to ask people in Korea, Switzerland, United States, Jordan, and Australia about the status of BCPs in healthcare. Now we have been trying to develop the system, how to evaluate and improve the BCP of hospitals and regional, and also BCP at regional levels. Okay, thank you.
Thank you. Thanks so much. Maybe Professor Yuichi is so tired, I think so. Yeah, no problem. Yeah, let's go to the Dr. Kwon. I'll ask for a few questions to Dr. Kwon. 우리 권 박사님한테, 권 선생님한테는 제가 질문을 드리겠습니다.
I'll ask a few
What is
questions
the
to
lesson,
Dr.
great
Kwon.
lesson to HIRA from other countries' experience and thought? First question. What do you think about that?
네, 굉장히 일단 오늘 오신 여러 강자
First of all, I'd like to
설명을 너무 잘 듣고
thank
저도
all
제
speakers for their
개인적으로는
wonderful
또
presentations
제가
today.
보험의료 시스템을 이해하는 한 단계 좀
And
업그레이드되는
personally, I
하나의 이제
think I was able to
중요한
upgrade my
계기가
understanding
되었다고
of the
생각합니다.
healthcare systems around the world.
하나의 교훈이 아니라 여러 가지 교훈이 있는데
I
결국은
gathered many
우리가
lessons,
고민하는
not just
것들을
one, but
다른
at the end of the
여러
day,
나라에서도 똑같이
the
고민을
challenges that we face in
하고
Korea
있다라는
are
부분이
shared by
있고요.
other
그리고
countries. That
우리가
was one lesson
중요하게
that I took away.
생각하는 그런
And
가치들을
also
또 다른 나라에서도
the
그런 의료지를
values that the things that we
향상시키는데
value here,
굉장히 중요하게
the
생각하고
values that
있다라는
we
생각이 이제
cherish here
들었습니다.
in improving quality
그에
of
더해서
care,
이제 하나
that's
더
also
말씀을
shared
드리면
among other countries,
저는
from what I gathered.
오늘 심평원이 이 세미나를 주최를 했고 저는 또
As you know,
굉장히
HIRA
대단한
hosted
사람이기
the
때문에
symposium, and
심평원도
I
중심으로
love
말씀을
working for
드리면
HIRA. So from that
결국은
perspective,
우리가 세계 다른 나라처럼 의료질을 향상을 하려고 하면
in our pursuit of improving quality of care, we currently heavily rely on the role of assessment.
심사평가원이기 때문에 심사는 사실 과학적 사실과 경제성의
There's two parts, like I said in my presentation, review and assessment. Review is based on scientific data, but assessment takes it a step further. It takes in patient aspect, also it looks at equity and affordability, and also diversity. I think as an organization in charge of these two processes, we need to respect diversity, and in that regard, I think we have been doing a pretty good job. Not just healthcare policies, but in terms of preventive care, and I think it encompasses the entire Medicare medical system. And we have diverse perspectives looking at the healthcare industry. I think there's a little bit of standoff between medical professionals on the field and also policymakers. In the past, we really try to focus on the quality of practices and how to improve patient experience. But these days, I think we also look at medical professionals' perspectives and try to take into consideration what they're experiencing on the field. But regardless of how diverse perspectives we take in, it's important and difficult to persuade the various stakeholders. But when it comes to HIRA, we try to emphasize communication when it comes to talking to stakeholders. I believe this is important for all countries as well. Thank you.
이런 토론 중에 자기가 애사심이 많다는 얘기를 대놓고 하는 경우는 제가 처음 들어요.
I think I've never seen someone saying that you love working for your own company,
I'm
but
surprised that the Dr. Kwon has too much lovely mind to HIRA. Yeah, thank you. Very nice. 예, 우리가 한테 15분 정도 남아 있어서 그 플로어에 계신 분들로부터 질문을 받는 순서를 가겠습니다. Thank you for your insightful statement. Now we'll ask to the floor for some question.
플로어로부터
Please
질문을
raise your
받겠습니다.
hand if you
질문
have
있으신 분은
a
손을
question.
들어주시고요.
Please raise your hand if you have some question.
질문 있으시면 손을 들어주시길 부탁드립니다.
If there is no question, I will designate because I was former executive director of HIRA, so I knew many person among the audience. 이게 질문을 안 하시면 제가 지명을 하겠습니다. 손을 들어주시기 바랍니다. 이거 혹시 이거 그 종합 심포지엄 국제 심포지엄 기획하시기 전에 이거 다 짜고 하는 거 아닌가? 원래 몇 명 지정해 놓지 않았었나?
I thought we assigned people to ask questions for this symposium. No, just a joke. Please raise your hand
없으면
if you have any questions.
우리 저쪽에 하품하고 계시는데 김남순 선생님 질문.
Kim-Nam-soon, I caught you yawning.
마이크로폰을 좀 갖다 주십시오.
Do you have any questions?
예, 저는 그 평가위원으로 일을 하고 있는 김남순입니다.
Hello, I'm
먼저
also a
말씀드릴 것은
reviewer
절대
for
하품을 하지
HIRA.
않았습니다.
And let me clarify one thing. I didn't yawn.
그 모든 그 여러 나라에서의 그 인증과 그다음에 이제
Today I was able to hear a lot of insights about accreditation and a lot of efforts that are going on to improve quality of care. And we especially talked about the importance of data and also, you know, putting burden on healthcare providers. And I believe it was mentioned that no policy or strategy can be perfect from the beginning. A lot of these things really resonated with me. I think there was a mention about 60-30-10, the ratio. When it was mentioned, data, knowledge, information, when these things are translated to the field, it will be very effective in improving quality of care. That's what I gathered from her presentations. But one thing that struck me while listening to that is that a lot of people here, including myself, a lot of people who also work in healthcare facilities, I think it's inevitable that we have profit-oriented mindset in today's society. So when caring for patients, the knowledge that I have and the attention that I give to my patients, it's not always easy to focus on only those things realistically. I mean, we should and have to continue to focus on those things through accreditation and other efforts. But these realistic challenges will be roadblocks. So when I don't think that we necessarily focus on these realistic challenges in terms of like societal or systematic challenges. So I'm sure that medical professionals on the field always face the challenges in their everyday practice. How, if we want them to focus on patients and not look at profits too much, what are the things that we should provide and what are the things that we can do for them? So Professor Braithwaite, any thoughts on this?
Dr. Braithwaite is appropriate respondent.
I do. That's an excellent question. Thank you for your responses. I wonder if I could say one positive thing and one negative thing. So the positive thing is that we often start with our quality work and our assessment work and our data work with the idea that the system has a problem that we have to fix. So if we're doing policy or data or setting new standards, we sort of think there's organizations that aren't meeting the standards, or that we have 10% of adverse events and we need to fix that. So we often start from a negative position. But actually, the amazing thing about healthcare isn't that it creates harm or adverse events in 10% of cases. The amazing thing about healthcare is in a system this complex, when so many things could go wrong, that 90% of care is actually delivered well. Because if there's 10% harm, then the other 90% is not producing harm. Now that's a remarkable result for a complex adaptive system. And Professor Stain showed, how you can make improvements. So we've published 6 books on safety 2, me and colleagues across the world, patient safety 2, which says, let's not just focus on things going wrong, Because, you know, when we do that, we essentially are saying to clinicians, you are making mistakes or you could make mistakes. But we can also focus on when things go right, because so many things go right. So many patients get good care. So understanding that is a very powerful thing for us to do. That's one thing. That's my positive thing. My negative thing is, if you think about it, you can't have everything. And we keep trying to have everything in a health system. But actually, if you think about a health system, you want three things. You want it to be good, you want it to be quick, and you want it to be cheap. Now, you can't actually have all three. You can have a good, quick system, but that won't be cheap. You can have a good, cheap system, but that won't be quick. And you have a quick, cheap system, but that won't be any good. So we're actually trying to reach the unattainable. We want a good, quick, cheap system. So that means we always have to make trade-offs. So my very wise colleague said, we can't have a perfect system. That's true. So what we do have is the capacity to continuously improve, but not think that we can ever get perfection. So I would submit that to you, Professor Yoon, as something interesting for people perhaps to take away and think about.
Thank you. Thanks so much. 아마도 충분한 답은 안 됐었겠지만 제가 듣다
I hope
보니까
that this was a good
굉장히
enough
이렇게
reply.
통찰력 있는
I think that he gave a very insightful response. Tomorrow, all of the panelists and presenters will visit HIRA in Wonju. So please, to the person who just asked the question, go to Wonju and give a follow-up question. Okay, does anybody have any other question? We have about 7 minutes remaining. We will take one more question. Okay, everybody is avoiding eye contact. Oh, okay, I see here. Can we pass the microphone?
Before you have a question, please introduce for yourself.
Okay, so I don't work for HIRA. My mom used to like 10 years ago, but today I'm here for liaison for Dr. Staines, and I have a question to Dr. Roos, and my question is that, so I believe that the telemedicine industry is at the early stage of booming, and I heard that Teladoc, the company, is one of the leading ones in the States. But considering their stock price has been tanking ever since early 2021. Do you think it's just that company's problem, or it's because people are getting skeptical about the telemedicine? And if you have any words to people who think they're not credible yet, what would you want to say?
Okay, I was hoping you were going to ask me something about baseball, but it actually, the answer is neither of the, as best to my knowledge, of the scenarios or reasons you proposed for the stock price drop, which is not something I typically follow, but I was aware of that. No, the real issue is the reimbursement in the United States. Is far more of a factor for the telemedicine and telehealth aspect. So the reimbursement system, so similar to universal health insurance in Korea, we have CMS, or Center for Medicare Services, which really Medicare is the primary payer in the US for those that don't have private insurance. During COVID, there were a lot of emergency rules put in place for billing, i.e. paying for telehealth. With the removal of the healthcare emergency, although as we watch what's happening, who knows if it comes back, the reimbursement for telehealth dropped. They took away the ability to pay for some of those, so it's either being paid for by some private insurances or people pay for out of pocket. But what's really creating a drop in demand is the fact that the government won't pay for the services. Fortunately, I think in many other countries that's less of an issue. At one point, I talked to somebody for the insurance company in China, and they were doing 1 million telehealth visits a day, or at least, I think it was actually, or was it? It was even greater than that. It was just a phenomenal number that we couldn't even comprehend. So I don't think I think telehealth is actually more in the future rather than less. It really, in the United States right now, it's a bill, who's paying for it? Which, if no one's paying for it, your stock price is going to go down. It's a great question.
Thank you. Thanks so much. 마지막으로 한 분
We will take one last question.
질문할 시간이 있을 것 같습니다. 혹시
Anyone? Any other question? One last question.
주신 선생님 계시나요?
Someone raised their hand.
갖다 주십시오.
Please give them a microphone.
자기 소개를 먼저 좀 부탁드립니다.
Please introduce yourself first.
Hello. Hi, I'm John. I actually come from Joint Commission International, so I'm Joel's colleague. I'm originally from Korea, so I speak the language, but I'll just speak it in English. Currently where I'm based, I live in Singapore, and there's this big initiative going on in Singapore. It's called the Healthier SG. So the government is trying to move away from having these patients going to the tertiary hospitals, but they are trying to bring in resources and including resources around IT infrastructure to make sure that patients and families are taken care of in the communities and the primary care. So this is really the shift towards empowering primary care, and sort of I feel like it's also empowering the patients to really take care of themselves. So I've been watching some of the slides where during COVID and after COVID fluctuations of the revenues of the hospitals and investments from the government authorities, ministries going into building the infrastructure. And I know we know most nations we're hungry always for more money that can go into healthcare. But how much do you think of this is really in the hands of empowering the patients and families so that they could take care of themselves? And I just want to get some ideas around from you, which some of you may, this is not a question directed to one particular person, but just wanted to understand, from the audience perspective, what other countries are doing to really empower the patients and primary care to really strengthen the system.
I think thank you for your nice question and comment. I think this from this audience that comment is not question but comment, please. Comment itself. So please keep in mind together. Yeah, because we finished our permitted time. Yeah. I'll try to close this symposium. This conference focused on preparing future healthcare system through improving integrated healthcare. We have shared groundbreaking insight from Keynote Speech and explored Western and Asian countries example from our session speakers. The insight and knowledge shared within these worlds will undoubtedly influence the academia, industry, and society. I'd like to appreciate to our keynote speakers whose wisdom has illuminated our thought, and to our panelists who gave us great presentation. I would like to close this symposium by thanking all of the speakers and participants for their informative and interesting presentation once again. Thank you. Thanks so much. Have a great day.
Thank you very much for leading the session. 네, 여러분 다시 한번 큰 박수 부탁드리겠습니다. And honorable speakers, please remain on the stage. We have closing announcement. 네, 고맙습니다. 여러분 이렇게 아침부터 저희 진행된
We started early in the morning. Now it has come to a close. Today, the gathering of healthcare experts and their insightful contributions have guided us through the profound discussions and explorations at the symposium. I hope they were really insightful and helpful for you.
다가오길 바라면서 이로써 저희는 오늘 준비된
So
모든
we
순서를
will
마치도록 하겠습니다.
close the symposium now, and thank you so much for participating offline. Thank you everyone who's watching online. With this, we conclude all segments of the 2023 HIRA International Symposium. Thank you so much.